Good morning, everyone, and welcome to Perfweb and this morning's Vanderbilt Faculty Forum, followed by the Tammy Sparacino Journal Club, followed by the John Ingram Knowledge Nuggets. I'm your host, Joe Basha. I'm here in the studio with my good friend and colleague, Tammy Sparacino. We're going to just absolutely jump right into this. I'm going to do all these opening remarks in the segue between the Faculty Forum and the Journal Club. So let's go ahead and roll the Vanderbilt Faculty Forum intro. It's been rolled? Okay, and we're going to go straight to Joey Lepore and to Dr. Patel coming to us from Vanderbilt. Hey, guys. Good morning.
Good morning.
Hey, good morning. How are y'all?
Doing fantastic. You guys look great. You look like you've been sleeping for days.
Yeah.
I'm sure this is going to be a very lively discussion. I know we changed the topic at the last minute, which is great. And this is going to be about the butterfly technique, COVID-19 and ECMO. So I'm really excited to hear about this. And Joey, of course, you've been with us before. You've participated in these programs. Everybody knows you, but none of us know that fine-looking young man to your left, Dr. Patel. So maybe you could introduce him to everyone, and we'll move forward with this very interesting topic and then hopefully very lively discussion after that's over.
All right. Yeah, absolutely. Today we've got special guest Dr. Patel. Did his medical school at Ole Miss, and now he's joined us. I believe it was July of last year as part of is it a 2-year fellowship for ECMO? Yeah. So he's in his second year now, getting extensive knowledge and plenty of experience in this field. Kind of joined us at the crux of all this COVID stuff. So jumped right in, and now he is kind of helping out the fellow that's in his first year of this program. So a lot of experience in this field, a lot of experience with this particular topic. So it's a pleasure to work with Dr. Patel here.
Well, Dr. Patel, good morning to you, sir. I'd like to ask you, if I may, I understand you went to Ole Miss, but are you by any chance a hockey fan, and have people ever called you Hat Trick instead of Yet Trick?
Yeah, I'm not familiar with hockey that much, but people have certainly called me Hat Trick.
So you're familiar with what a hat trick is, I'm assuming.
Right.
Yeah,
right.
They're very good. So I'll have to remember that. So next time I see you, I'll bring you a box of hats. In fact, we got a box of hats. I'm going to probably send you a couple of hats, as a matter of fact. So
yeah,
what is your fellowship? I understand is in ECMO. What is your end goal? So are you doing thoracic surgery? Are you doing intensive care medicine? What is exactly sort of your pathway here, so the audience kind of understands what perspective you're coming at this from?
Sure. I did my medical school at the University of Mississippi, and I've in the middle of my general surgery training here at Vanderbilt. As part of my training in general surgery, a lot of us take some time off in the middle of our training for research. And as part of my research years, I've decided to do this ECMO fellowship under the mentorship of Dr. Baketa. So that's currently where I am. Is I've done 3 years of general surgery. This is my second year of the ECMO fellowship, and ultimately, my plan will be to finish up general surgery and then ultimately start the cardiothoracic surgery fellowship here at Vanderbilt.
I also noticed on your CV something fascinating to me is your interest in xenocross circulation. And certainly I think that, knowing Dr. Bailey the way we did, and of course the very famous xenotransplant, cardiac transplant with baby Faye and all of that kind of thing, and of course cross circulation coming from, many, many years ago, predating the development of the heart-lung machine. Can you kind of give me an idea of what xenocross circulation really is for and what it entails?
Sure, and part of that is I was introduced during the ECMO fellowship as part of Dr. Baqueta's lab, who has been, doing kind of mechanical support and ex vivo organ perfusion for many, many years. And part of his research essentially looks at how do we address the organ shortage when it comes to lung transplantation, even liver transplantation and heart transplantation. And part of his research focuses on cross-circulation of organs. So essentially just to kind of briefly summarize what we're doing in his lab is a lot of times so many organs, specifically talking about lungs, they go unused just because of the organ quality. They're just not suitable for transplant, and a vast majority of these lungs from donors go unused just because of poor quality of the organs. So the question becomes, how do we rehabilitate these organs that are not initially viable or usable for transplantation, and how do we support these organs and recover them to get them to a point that we can transplant them into humans? And part of this research focuses on kind of xenogenetic cross-circulation, essentially where we're taking, it kind of goes off on the idea of ex vivo liver perfusion that we currently use for lungs, but takes it a little bit a step further in that we're essentially right now using animals and essentially using cross-circulation and supporting these organs, these human organs, lungs, on this xenogenetic cross-circulation platform to rehabilitate these organs and get them to a point where they potentially could be used for transplant. So essentially we have an animal who is hooked up to this cross-circulation platform that has the organ on it, and we support these organs and recover them potentially and get them to a point where they could potentially be used for transplant. So a lot of exciting things happening in that lab. But that's kind of the basis of it is the underlying question that we're trying to address is how do we solve this organ shortage problem that we have in the world.
Yeah, we definitely do have an organ shortage problem. There's no doubt about that, and especially with lung transplantation. I don't know how many of those you guys are doing over there, but certainly here in Houston, we have, I think reasonable success, but it's a difficult operation and a difficult post-op course for patients who get double lung transplantation. It really,
Right.
It gives you some time, but it's not necessarily it's not quite as easy as heart transplants. I don't necessarily understand exactly why the post-operative course is so much more difficult, but it just seems to be.
Yeah, certainly. And this research in xenogenetic cross-circulation is hopefully
Magic.
Hopefully provides some answers in how do we not only increase the donor kind of organ availability, but also, how do we improve the lifespan and kind of hopefully survival of these.
Yeah. That's very interesting, Dr. Patel. Thank you so very much for that overview of that. It really struck me because I do think xenotransplantation is a viable alternative to human donor heart and lung and kidney and everything else transplantation, but it really lost significant ground because of people that animal rights activists and so forth. And certainly I understand that, but it's a complex problem. We have a tremendous need for organs and just simply not enough of them. But Joey, I'll let you take it from here. I'm going to be quiet. I know that I have a hard time doing that, and we'll go ahead and get Dr. Patel started with his slides. Are we running the slides, David, or is he?
Yes.
We're running the slides. So Dr. Patel, if you'll just say next or whatever you want to say, that'll key us to go ahead and advance the slides for you.
Sure. Sure. So, I have just a few slides to give an overview of exactly what we've been doing with some of these incredibly difficult patients with ARDS secondary to COVID-19. And we're essentially, for VV ECMO, we're doing something called parallel circuits, or a nickname for that's become the butterfly configuration. But I'll just give a brief overview of the physiology that we're really trying to address, and why this specific configuration has the potential to provide benefit for these extremely sick COVID-19 patients. Next. So just to recap, and everyone knows this, the goals of VV ECMO is to support a patient's hypoxemia and hypercarbia from their respiratory failure to allow lung rest and promote subsequent recovery. So when a patient goes on VV ECMO, prior to going on ECMO, they're usually on mechanical ventilation that is likely injurious to the lungs. They're on high pressure mechanical ventilation, high FiO2. Most of these patients are deeply sedated, paralyzed on inhaled vasodilators. So once a patient goes on VV ECMO, the objective of ECMO is not going to do anything to reverse the underlying physiology, the pathology that's happening, but the goals of ECMO are essentially the most important thing is to promote lung protective ventilation. So as soon as the patient goes on VV ECMO, we really turn down the ventilator settings to promote lung rest and recovery. And additionally, we really want these patients to be awake and not neuromuscularly blocked, not chemically paralyzed, because prolonged sedation and neuromuscular blockade has a whole host of side effects and issues that we can't really deal with in these extremely sick patients. So very important to remember that as soon as the patient is on VV ECMO, we really want them to be on lung protective ventilation to hopefully promote lung recovery. So the ultimate goal is to liberate them from VV ECMO. Next. So VV ECMO is very straightforward. It's very easy. The physiology is not complex at all. So the most important concept to understand is that in VV ECMO, the higher the ratio of the ECMO blood flow to a patient's cardiac output is essentially determines how well a patient will be supported. As we all know, cardiac output is just the volume of blood that's being ejected by the heart per unit time, so usually measured in liters per minute. And all that to say is that the goal of ECMO, the goal of the cardiac output is to promote oxygen delivery to the vital organs. So, you know, just to keep in mind, oxygen delivery, the formula, extremely important to understand, is the cardiac output multiplied by 1.34 times the hemoglobin times the oxygen saturation of the blood. There's also a component of it that's very insignificant, which is the partial pressure of oxygen in blood, which really contributes not a whole lot to the oxygen delivery formula. But essentially, the most important concept in VV ECMO physiology is the higher your ECMO blood flow to a patient's cardiac output, that determines how well the patient will be supported. So, for example, if a patient's cardiac output, no matter how you measure it, if a patient's cardiac output is, for example, 6 liters per minute, and you are flowing the patient at 3 liters per minute on VV ECMO, that means that at 50% of the blood that enters the patient's right ventricle before going to the pulmonary circulation will be richly oxygenated blood that's coming from the ECMO circuit. So 50% of that blood will be adequately oxygenated before going to the lungs for even more oxygenation and decarboxylation. So for the most part, if you are at that 50% number, 50 to 60%, if your ECMO blood flow to the patient cardiac output ratio is 0.5 to 0.6, then for most instances, you will be adequately supporting the patient with those flows. The problem is when you have these extremely sick patients who have an elevated cardiac output from a variety of reasons, whether it's increased metabolic demand, whether it's a septic state, whatever the reason is, these patients are extremely sick. They are in this incredibly intense inflammatory state with a hyperdynamic circulation. The problem is these patients have an extremely high cardiac output. And if you're only getting 4 to 5 liters of ECMO blood flow with a single circuit, but their cardiac output is 10 liters, 12 liters per minute, you're really getting less than 50%. You're capturing less than 50% of their venous return. And the problem is all of the blood flow that's not passing through the ECMO circuit has to rely on the lungs for oxygenation and decarboxylation. The issue is these patients' lungs don't work at all. And the degree of lung injury is something that we've really not seen with normal ARDS. And the degree of lung injury that these COVID-19 patients have is truly extraordinary, and their lung compliance is almost nothing. A lot of these patients have tidal volumes of 20, 30, 80 cc's, which is nothing. So all of that blood flow that's not captured by the ECMO circuit has to rely on the lungs for oxygenation, and these patients' lungs just don't work. So all of that blood flow that's not going through the circuit is not getting oxygenated before going to the systemic circulation. Next slide.
So can we interrupt just a second?
Hold on, Dr. Patel.
Sure.
Go ahead.
Can you put your mic on your lanyard instead of on your shirt?
Sure.
I think we're getting a little feedback. Okay,
Is that better?
perfect. Thank you.
Thank you.
So this is a very typical X-ray of what some of our sickest patients look like. As you can see, there are really no lungs. Lungs are completely consolidated. These lungs do not participate in gas exchange. So these lungs have a tidal volume of 80 to 60, cc's on lung protective ventilation, and and this is not uncommon. This is what we typically see on chest X-rays for these incredibly sick COVID-19 patients. Next. So like I said, these patients have an increased cardiac output from an increased metabolic demand. They're extremely sick. They have this incredibly intense inflammatory reaction to COVID-19. They have a hyperdynamic circulation, and all that to say is that they have an elevated cardiac output. And the relationship between, the relationship between VV ECMO cardiac output and a patient's blood oxygen saturation is pretty simple to understand. So this is an actual patient we captured cardiac output data on who was on VV ECMO with an ECMO blood flow around 5.5 to 6 liters per minute. As you can see, the blue line represents the patient's cardiac output, and the orange line represents the patient's oxygen saturation measured by pulse oximetry. So what essentially happens is as when a patient's cardiac output goes up, when the specific patient's cardiac output goes from 10 liters per minute to 12 liters per minute, the oxygen saturation declines. And why is that? It's because at a set blood flow of 5.5 to 6 liters per minute, what's happening is when the cardiac output of this patient goes up, we're capturing less of their venous return through the ECMO circuit, and more of it is passing through into the lungs without being oxygenated by the ECMO circuit first. So as soon as the patient's cardiac output goes up, with a set ECMO blood flow, the patient's the blood saturation will decrease, as you can see.
Mm-hmm.
So even with 5.5 to 6 liters per minute, when this specific patient's cardiac output goes up to 12 liters per minute, their oxygen saturation drops to the 80s. And this is on about 6 liters of ECMO blood flow, and we're still sitting in the 80s. And as soon as the cardiac output comes back down, goes back down to 8 liters per minute, that just means that now we're capturing, that ratio of ECMO blood flow to patient cardiac output is higher. So as soon as that ratio goes up, we're now better supporting the patient, and you can see that the oxygen saturation goes up. So increased cardiac output with a set ECMO blood flow means that now we're capturing less of the patient's venous return that's passing through the circuit. So that just means the patient's going to be less supported. So, and this is actual data from a COVID-19 patient, and you can see it's not uncommon for these patients to have an incredibly high cardiac output of 10 liters, 12 liters, 14 liters per minute. And if you're only getting 6 liters per minute and the patient of ECMO blood flow, and the patient's cardiac output is 14 liters per minute, you're capturing less than 40% of that patient's venous return through the ECMO circuit, so the patient's not going to be supported. Next
And
slide.
that's pending. And that's do you mind if I just ask you a couple of questions during all of this, or would you rather finish all of your slides first?
No, go ahead.
So these are very good points, and we see this phenomenon a lot. And I sort of call it a VQ mismatch of the ECMO circuit and the patient. So it's sort of like a perfusion deficit that you see in the lungs. You've got perfusion but no ventilation. And the same phenomenon occurs. And of course, your flow may be 6 liters on the ECMO, as you said, but that's pending 0 recirculation. So you even have to consider now your effective ECMO flow. but you,
Right.
in my view, and I don't know how you address this, but you probably have it in your slides moving forward, and I'm going to wish I hadn't bothered you with this, but I'm struggling with the treating a number to have a higher saturation by depressing the cardiac output with beta blockers, but that then results in me reducing DO2 to the actual tissues out in the rest of the body. So I don't know if that's something that you have thought about, considered, and maybe given more thought to, and have an answer to that concern.
Right. And yeah, we've certainly thought about that. So ways that we can address this issue, and again, it really is sometimes treating a number. We know that, from studies that probably having an oxygen saturation above 88% is probably adequate. What happens when a patient is persistently, when their saturation is 82% and the PaO2 on an arterial blood gas is 52? Is that going to does that mean anything? And the answer is we don't really know what the lower limit of an acceptable blood oxygen saturation truly is for a prolonged period of time. We don't know. It's probably bad, but we really don't know, especially if the patient is not generating a lactate and they're satting 82% persistently. Is that bad? And the answer is we truly don't know if that's okay or not. But to address, what are other things that we can do to depress that cardiac output? And as you put it, yes, beta blockade is certainly an option where as soon as you reduce a patient's heart rate, that cardiac output will come down and you will support the patient better on ECMO. But the problem with that is yeah, you're potentially reducing oxygen delivery by giving a beta blockade, but that's probably not the case, because even in the cases that we've done that, we don't really see an increase in lactate or anything like that signals to us that there's inadequate delivery of oxygen. But beta blockade for most of these patients is not very possible just because of their tenuous hemodynamic status. A lot of these patients are septic just from viral pneumonia from COVID-19, and they're hypotensive on vasopressors. So we really just don't even have the ability to give them beta blockade.
Yes, very good point. And the other thing I'm curious of is, and maybe the higher number, the higher saturation, isn't just a number, because what we're seeing is those patients with this persistent low saturation, 82, 86, 84, that we're seeing, by leaving them like that, evolving and worsening right heart failure, ostensibly from the pulmonary hypertension that may be being stimulated by the hypoxic environment. So we're struggling. I mean, I'm really interested to see what your guys' outcomes are, and I'm really interested in this dual circulation, but concerned about whether or not the COVID-19 lung failure is really a salvageable condition, or if transplant really is the only real solution to the problem. But I'm sorry, I don't mean to interrupt you.
Yeah, and to the last comment is we don't know at this point in the game. We have no idea if these specific patients that progress to this degree of lung injury, whether or not that lung injury is reversible, or whether transplantation is the only option. We really don't know where that line is, where we can say this patient's lungs will not recover and he needs a transplant, or there's still potential for recovery. We really just have no idea. So next slide. So we kind of already briefly touched on this. Why do we need all of these things? We struggled early on in the pandemic for a lot of these patients that we were putting on ECMO. Is even with high ECMO flow, 6 liters per minute, 6.5 liters per minute, an additional drainage cannula, whatever, we were really having difficulty supporting these patients. These patients, like I mentioned in the very first slide, the goal of EV ECMO is to promote lung protective ventilation. What was happening for a lot of these patients, even with maximum ECMO blood flow with a single circuit, these patients were persistently hypoxemic. We weren't able to wean their sedation. A lot of these patients remained chemically paralyzed in an attempt to kind of improve their oxygenation, and we just could not support them. And a lot of patients early on did not survive, and we just really struggled to really support these patients. And that's where the idea of potentially increasing support by giving adding in an entire second circuit to achieve ECMO blood flows of upwards up to 8, 9, 10, 11 liters per minute in some patients to support them enough to where we could promote lung protective ventilation. We could turn down the FiO2 from 100% to 50%. We could turn down their driving pressure and really turn down their peak pressures. Having the ability to give a patient 8 to 10 liters of blood flow allowed us to wean sedation, allowed us to unparalyze them. So, all of these things, the factors that go into it is these patients' lungs don't work. The subset of patients that get this sick, that have this degree of lung injury, their lungs don't work. They have an elevated cardiac output, whether it's from sepsis, whether it's from this intense inflammatory state, whatever the case is, they have an elevated cardiac output. They have increased physiologic demand that, with a single circuit, what we were doing is we were just, sedating these patients. We were paralyzing for days and days and days. Some patients stayed, paralyzed for weeks just because we weren't able to wean paralysis because of hypoxia. And we just weren't protecting them on the ventilator. We know that, when you're beating up the lungs with high vent pressures, and a patient stays on 100% FiO2 for a long time, you're promoting hyperoxic lung injury, you're promoting lung injury from the ventilator. We just weren't able to do that with a single circuit for some of these patients, and that's kind of where we kind of started doing this parallel circuit and adding in a second circuit to better support these patients.
Yeah, I've never seen so many. I've never seen so many pneumos in my life. I noticed your X-ray. Your patient had a chest tube in. All of ours have chest tubes in. We put a chest tube on one side for a right-sided pneumo, and then as soon as we put the right-sided, we fix that. The left side blows.
Mm-hmm. Yeah, and I kind of wish I would have put a couple of other X-rays, but yeah, that's a very typical X-ray. This is not like I didn't pick one that was like the sickest, that's out of the ordinary. Like this is the X-ray that we see for a lot of these patients, and as pneumothoraces and barotrauma are incredibly common in these COVID-19 population, and patients that get this sick, sometimes a pneumothorax goes unnoticed because a lot of times these patients will have a very large pneumothorax and we won't catch it just because it just tells you that their lungs aren't working. With a lung completely down, a lot of times we won't see any change in their hypoxia if they're on VV ECMO, just because if that lung goes completely down, it doesn't matter really because the lung's not doing anything anyways. And in our medical ICU, it's not common to get an X-ray every single day unless there's a clinical indication. So sometimes we miss pneumothoraces because the patients will get a pneumothorax, but we won't know because they're on VV ECMO because their lungs are doing absolutely nothing, and that's how bad the lung injury is. So next slide.
So one of the things real quickly that I've started doing, and I've noticed this pretty consistently, is on the ventilator, I make sure that the VTI and the VTE are clearly visible. And when I see the VTE, 50 cc's every breath lower than the VTI, and the patient starts showing any signs of hemodynamic instability, we do an X-ray and almost always find a pneumo. Now, a few times I've been tricked, and it wasn't there. There was a leak somewhere else. But if those two numbers aren't pretty close and matching, you've got a leak somewhere. The air's got to go somewhere.
Mm-hmm. Yeah. And certainly, that's a very good point. And anytime there's a discrepancy in the tidal volumes, there's a discrepancy in the inspiratory, expiratory volumes. The ICU teams are very good about getting X-rays when they're clinically indicated. But a lot of these patients, like we have a couple right now, their tidal volumes are literally, 80 cc's per breath. If their tidal volume goes down to 60 cc's, does it really mean anything? Probably not. But that's how poor their lung compliance is. And like you said, these patients have leaks elsewhere, and we struggle with leaks around the tracheostomy. They have, when we try to wean sedation, these patients have this incredible drive to cough, essentially, just from their really terrible lung compliance, and they don't tolerate being awake. And this vigorous coughing results in kind of probably this tracheal dilation, and now there's not a good seal between the trachea and the tracheostomy balloon, and we have a leak there. And so it's like you put it, looking at the ventilator is a very good way to diagnose a pneumothorax sometimes, especially in the setting of hemodynamic instability. But it's all that to say is that these patients have extremely sick lungs. Barotrauma-induced pneumothoraces are extremely common, and we see that all too frequently. But for these patients that we weren't able to support on a single circuit, we tried beta blockade, but like I mentioned, a lot of that's not possible because they're hypotensive on vasopressors, a lot of these patients. We assured that they weren't having clinically significant recirculation. Chest x-rays we made sure that the cannulas were adequately positioned, and we ruled out recirculation for most cases. We typically, a lot of these patients, when they're febrile, their cardiac output goes up. We use the heater cooler as much as we can to bring down their core temperature to reduce metabolic demand. But again, it's just all of those things are just not adequate enough to support a patient whose cardiac output is 14 liters per minute. And sometimes the alternative is to just deeply sedate them and paralyze them. But again, doing that for weeks and weeks is just not a viable option. So that's where this idea of using an additional circuit in parallel to get even more flows of anywhere from 8 to 10 liters to better support these patients. And since last August, we've for this specific kind of configuration, we've supported about 13 patients, if I'm not mistaken. Again, most have been male. All of these patients have a high BMI, but again, it's kind of the norm in Tennessee. And we're extremely selective in who we offer this configuration to. And there's, in all honesty, we don't have a guideline in place or a protocol in place that tells us who we should be, adding in a second circuit to. We'll talk a little bit more about that. Next slide. So this is what the typical configuration looks like. Initially, on the right side of the screen, the picture on the right side is what we initially did, where we have essentially it's two completely separate circuits. So we have a drainage cannula in the right femoral vein. We have a return cannula in the right internal jugular vein that's going to one circuit. And then for the other circuit, we have another drainage cannula in the left femoral vein, and then return cannula in the left IJ. The first three patients that we did this for, this was the configuration. It's with this configuration, having two large bore cannulas in the IVC, our preference now is when we're putting on a patient for COVID-19, our preference is to use large bore cannulas right off the bat. So the drainage cannula that we put is a 27 French, and the return cannula in the IJ is a 25 French.
Wow.
So
That's
just
big.
to essentially get as much flow that we possibly can with a single circuit, because these patients get really sick. But even though we found having two large bore cannulas in the IVC it really resulted in no thrombotic complications that we saw. And the theoretical issue with having two large bore return cannulas in the IJ is you potentially could have kind of cerebral outflow venous obstruction. But we never saw that in any of our patients, really. But that theoretical risk is always there, is if you form clot around these cannulas, now you're impeding venous drainage from the brain. That could certainly result in bad complications. So that the theoretical risk is always there, but we never saw it in any of our patients. So what we started doing was to avoid cannulating both of the internal jugular veins. We started for the second circuit that we would add in parallel. We would still add in a second drainage cannula in the contralateral femoral vein, but the return line would now, we started wiring into the return cannula of the first circuit. And this was possible because, like I said, we use a large bore cannula to begin with. In the right IJ, we put a 25 French. So we found that using a large bore cannula, it was easily able to accommodate flows of anywhere from 8 to 10 liters of total flow going through that single return cannula with reasonable outflow pressures. And we never really saw any significant hemolysis specifically from this configuration, from either one of these configurations. So again, the limitations that we're overcoming with this dual circuit configuration or parallel circuit configuration is that we're able to achieve ECMO blood flow of 8 to 10 liters per minute, which is not possible with a single circuit because most oxygenators have a rated flow of 7 liters per minute. So we're overcoming that limitation. We're overcoming the limitations of you just can't get 7 liters of consistent flow with a single circuit just because the size of your drainage cannula, you have increased venous drainage pressures. With a single circuit, it's just not possible to get those kinds of consistent flows. And especially not possible when a patient is awake and coughing, and with a single circuit, it's just not possible to consistently get even 7 liters of flow. Mm-hmm. So having two circuits in parallel, independent of one another, is what makes it possible for us to get a total ECMO blood flow of 8 to 10 liters per minute. And with that, I'm sure there's some degree of increased recirculation because of this, because you're flowing so high. But this is, this configuration for a lot of these patients made it possible for us to lessen their sedation, to unparalyze them, to protect them on the ventilator. For a lot of these patients, as they began to show signs of recovery and were awake, we were able to support these patients, and they were able to do physical therapy because of the fact that they're on two circuits, and we were able to provide them with 8 liters of flow during physical therapy. So next slide. And we don't, this is something that we are extremely careful about doing. We don't entirely know who we should be doing it for, in all honesty. When do we pull the trigger on putting in a second circuit? We really don't know. We don't have a rigid guideline in place to let us know when we should take that route. And like I said, for all of our patients on VII ECMO for COVID-19, we go down the traditional pathway. If they're not supported, what can we do to better support them? Can we beta block them? Can we rule out recirculation? Is the oxygenator working? Can we optimize the patient's mechanical ventilator? Are they febrile? Can we bring their temperature down? Can we add a drainage cannula first to get a little bit more flow to support them? So that is the pathway that we go down. But a parallel circuit is not something that's in our protocol, in our pathway. So we're extremely careful about who we should do this and provide this therapy for. And as of right now, we really don't know who and when we should be doing it for, and when we should pull the trigger on going to a completely second circuit. But some of our indications are the patient that we put on VIV ECMO, are they on 100% FiO2? Can we not bring their mechanical ventilator settings down? Are they needing to be deeply sedated and paralyzed for a prolonged period of time, and we can't unparalyze them because of hypoxia? So those are all, and is it a young patient in single organ failure, without renal failure? It's not like, a 60-year-old that we're doing this with, but is it a young, healthy, otherwise healthy patient in single organ failure that's been paralyzed now for a week on maximum mechanical ventilation that we can't wean? Those are the kinds of people that we're considering putting in a second circuit for. And really, the biggest thing is the ethical implications and the fact that this is such ECMO already is an incredibly resource consumptive therapy. Now you're talking about adding in a second circuit. So the ethical implications of those are massive. And at the height of the pandemic, are you really willing to tie up two ECMO circuits for a single patient who will invariably be on 2 circuits for weeks and weeks and weeks, if not months. The fact that now you have a patient on 2 circuits, you're potentially depriving another patient of a life-saving therapy just because you don't have enough circuits for everyone. And is it fair for a single patient to be on 2 circuits for months and another patient not to get ECMO just because you don't have the resources? And certainly with 2 circuits, that just means more blood coming into contact with a foreign surface, increasing your risk of bleeding. ECMO is already coagulopathic in any patient, and now you're talking about adding in 2 circuits. So you're just adding to that coagulopathy possibly and increasing the bleeding risk. And like I said, you have 2 cannulas in the IVC. You have a large bore cannula in the IJ. There's always risk of thrombosis and clot formation around these cannulas. These COVID patients are already coagulopathic. They're hypercoagulable. And now you have 2 oxygenators, 2 pump heads. All of those things have the potential of forming thrombus, and it just means that you're going to have more circuit changes, more oxygenator changes, more pump head changes, whatever. All that to say is that it's going to be an incredibly resource consumptive therapy, and we are extremely careful about who we're going to provide this therapy to, but we truly don't know exactly when the right time to do it is, and who the ideal patient is. Our thought is that young patients in single organ failure that have the potential for a lung recovery is who we should potentially be offering this therapy to. Next. Okay. I think that's it. Hopefully that made a little bit of sense, and happy to have a discussion and answer any questions.
No, that was Dr. Patel. That was incredible. I mean, that was great.
Fascinating.
Absolutely. I get the idea. I think it was you I was asking this morning. I was asking Joey. I don't get the butterfly thing, but now I do with the double IJ and the 2 circulations going on. Kind of catchy. You mind if I ask? Well, actually, you know what? I ask a lot of questions. Tammy, would you like to ask some questions, and I'll jump in maybe later?
Yes, I just have a couple. Dr. Patel, that really was quite excellent. Thank you. My first question is the pathway for these patients, since you don't really know, you can't pre-select them if I'm getting the gist of how you're going about this. It's really more clinically, you just see that the circuit is not supporting them. So do you typically go from VV to VVV to then the butterfly circuit, or do you just skip the middle step?
Yeah, no, that's a great question, and certainly we like to avoid that if we can. For example, if we have a patient, excuse me, that's on ECMO, we're getting 4.5, 5 liters of blood flow, and they're not really supported, and we're limited in increasing our flows, whether because it's the cannula size or the cannula positioning, whether we're having elevated drainage pressures, whether is the cannula malpositioned, whatever the case is. If that's the case, we're not able to flow more than 4.5, 5 liters, 5.5 liters of flow. The next step in my mind would be to potentially add a drainage cannula to see if we can get an extra liter and get them up to 6.5 liters on 1 circuit to support them. But if, like I said, we're putting in large bore cannulas for these patients to begin with, a 27 French. And if a patient's already at 6 liters of flow with a single drainage cannula, does it make sense to add in a drainage cannula for VVV ECMO? Is getting 6.5 liters of flow going to do anything really if they're already not supported?
Right.
If they're already deeply sedated and paralyzed, is that extra half a liter of flow going to do anything? Is it going to allow you to be unparalyzed and wake the patient up? Probably not. So in that scenario, if the patient's already flowing 6 liters with 1 cannula, in my mind, it's probably, and the patient's cardiac output's like 14 liters per minute, whatever the case may be, adding in a drainage cannula and going to VVV ECMO is probably not going to make a whole lot of difference.
Right.
So in that scenario, I would probably, we would think about just going straight to a parallel circuit. But for that patient that maybe the cannula is a little bit too low and we're having flow issues and access insufficiency, Because of cannula positioning, maybe we put in a smaller cannula for whatever reason, and we're not able to get more than like 4.5 liters of flow. In that scenario, it would make sense to try a drainage cannula first to see if we can get more flow to support the patient more before going to parallel circuits.
Okay, thank you for answering that. Go ahead.
Anything else?
Well, my only other question is sort of a silly question, but so if you are on the dual parallel circuits, are you just splitting your flow support equally?
Yeah.
Since
Yeah,
yeah,
that's a great question. Yeah, so yeah, that's a great question, and yes, that's typically what we're doing. Is we're trying to we essentially try to mirror the flows. So if a patient needs 8 liters of flow, then we have 4 liters of flow with one circuit and 4 liters of flow with the other circuit.
okay,
Yeah.
yeah, okay, that's really all the questions I have.
That's interesting. Joey, do you have anything you want to talk about? Because I'm probably going to have some really good questions for you too, from a perfusion clinician management perspective as well.
Yeah. No, I just wanted to maybe make the point. I think with the increased RPMs with the single circuit, you have to remember, it's a lot of shear stress on the blood cells, and so to increase your flows, or the parallel circuit allows us to get higher flows, ideally with less RPM. So, that was just something that I wanted to point out.
That's a very good, actually, that's a really good point.
And if I may, I'll ask you a question about that. We have been noticing that we are having to go with higher RPMs than I'm typically comfortable with. We've really been pushing the capacity of these single circuits. What are y'all seeing there when you're on a single circuit? What's the maximum RPMs that your team still feels comfortable in using?
And it probably depends on which circuit, which pump they're using. So let's say percentage. So
yeah,
do you like to be at 70, 80, 90, or max?
Right. Do you understand what I'm asking,
We
Joey?
don't, yeah. Sorry, yeah, and Joey I may have a better idea than I do, but I don't think we have an upper limit of normal where we will say, we will not increase the RPMs above this limit. What we do is clinically, we trend these patients' hemolysis labs very frequently, and a lot of times we see exactly what Joey says is sure, we can probably get 6 liters of flow, 6.5 liters of flow with a single cannula and a single circuit. But what we'll start seeing is that the patient's hemolysis labs will go up, their LDH will start going up, their haptoglobin will start going down, their total bilirubin will start going up, and that for us is a marker of this is too much RPMs for this patient, and we're increasing the shear stress. So we don't have an upper limit of where we'll say we're not going to increase the RPMs above this. It really is patient dependent. Some patients will tolerate 6 liters of flow just fine, others won't, and they'll start hemolyzing. So it's more of a clinical, if we're clinically seeing hemolysis and that trend is going up, then we know that maybe the RPMs are too much for this specific patient.
Yeah. Okay.
So if I may, I want to talk about your cannula. So you start off with the 20. You said a 27 for your access cannula in the femoral. Now on the IJ, the 25, Joey, what kind of cannula is that, and where are you putting the tip? Is it a dispersion tip? Is it a single outflow? What are you using?
Yeah, it's basically a reinfuse. It's an arterial cannula. It's a 25 French Medtronic. I can't remember the Biomedicus. So it's just like it could be used as a venous drainage, like a short venous drainage, or an arterial, reinfusion cannula.
Where do you put the tip? Is the tip stay in the SVC, or do you advance it into the right atrium?
We typically, it's right at that SVC right atrial junction is where we shoot for it to be. But if it's in the right atrium, if it's in the SVC, probably doesn't make a whole lot of difference. We're mostly concerned from a position standpoint about the drainage cannula. And what we'll typically do when we cannulate these patients is we'll purposely have the cannula, overshoot, and we'll have the drainage cannula up higher, just because if the cannula is too high, if the drainage cannula is too high and we're getting recirculation, it's easy enough for us to pull the cannula back always, you know, with it, after looking at the X-ray. But once the cannula is in at our program, we avoid advancing the cannula just from an infection standpoint.
Sure.
We just don't do that.
Especially in the groin.
Yeah, exactly. And having the cannula too low is a bigger problem in my mind, because when it's in that intra-abdominal portion of the IVC that's collapsible, every time the patient coughs, you're going to lose flow. So, so we like for our initial placement of the drainage cannula to be a little higher. So, you know, if we're having recirculation, we can always pull it back. But if the cannula is too low, then we're definitely going to have flow issues. But as far as the reinfusion cannula, we shoot for the SVC or that SVC right atrial junction.
Joey, are you guys using the ELSA-meter?
No.
No. So are you're just measuring recirculation by looking at the return saturation? And another question on to that same point: do you put a swan in everybody?
No.
No swan. And Joey, so how are you determining recirculation?
Well, I mean, if it's, obviously if it's bad enough, when we first go on, it's pretty visible. You're seeing flashes of bright red blood, watching patients sat, and then, we have a SVO2 monitor.
So you put that on the circuit itself. So if you start off with the cannula.
We have a cardio help that'll monitor it, and then the spectrum system is what we also have. We'll monitor it as well. So and then early on, if we didn't have when we didn't have those systems, we'd just pull a gas off the pre-oxide and measure it that way.
So what about your anticoagulation strategy? So we have multiple hospitals that we do this, and some of them, or a couple of, well, one in particular has not gone to a full zero anticoagulation strategy. The other hospital has almost exclusively gone to that with aspirin and Plavix, given either PO or rectally, one or the other. And what is your guys' experience with anticoagulation?
Our anticoagulation strategy has not changed for COVID-19 patients. We still, initially, if the patient has no other indication for a higher anticoagulation goal, if they don't have any DVTs or PEs, then our strategy is still, for us, we typically use PTTs to monitor anticoagulation, and for us, it's a PTT goal of 40 to 60.
40 to 60.
Unless the patient has an indication for a higher goal.
Okay.
So you go ahead and use heparin. You put it on you do your initial bolus for cannulation and all that kind of stuff. Let the PTT come back down. Start your drip at whatever rate you're going to start it at, based on the patient's weight, and try to achieve a 40 to 60 PTT goal. And I mean, we're trying not to monitor it as often. We're about every 6 hours. Are you doing Q6 PTTs or longer than that, or what's your standard on that?
Yeah, and that's dictated by kind of the ICU. Essentially, I think our protocol in the ICU is once the patient reaches the goal PTT of where you want them to be, then you can start spacing out getting PTTs every 6 hours once the patient reaches that goal.
Yeah, that's what we do as well.
And temp control. Do you based on these findings of these patients that you're discussing, where we cannot flow enough with a single circuit, and they are intubated and they are paralyzed, heavily sedated, paralyzed, what is your feeling on using essentially therapeutic hypothermia, dropping them down to, say, 35 degrees, just to control their metabolic requirement while you try to figure out what we're going to do to achieve a high control of their hyperdynamic state.
Yeah, and we've certainly thought about that, and occasionally, you know, we will have a patient that's extremely febrile, who, and you know, that fever is definitely contributing to their elevated cardiac output and their increased demand. And we don't have a protocol in place to do therapeutic kind of hypothermia. Again, because our goal is to, and you know, with hypothermia, you're also you know, kind of inducing coagulopathy, and these patients, as hypercoagulable as they are, because of their underlying COVID-19 kind of pathophysiology, they bleed. These patients bleed. They bleed from the cannula sites. A lot of these patients, they've had GI bleeds. They bleed, and we worry, really, in all honesty, about bleeding more than we worry about clotting, because when a patient becomes coagulopathic, has a GI bleed, it's extremely difficult to control, and you know, cooling that patient and promoting that hypercoagulability, or you know, it just, we worry about bleeding, and we've just found that, you know, lowering their temperature really doesn't do a whole lot to better support them. And you know, it's not like all of these patients are febrile to 38 or 39, and we really need to cool them, and that's the underlying reason that they're not supported. Most of these patients are, you know, within the 37, you know, 36, 37 temperature range, and it's not like fever is a big deal. Like, for most of the patients, they will be febrile for a period of time, but for the most part, the fever breaks with medications and cooling and things like that, to where it's not like they're febrile for days and days, and that's the sole reason that their cardiac output is high, and they're not supported. It's part of it, but I don't think it's the major driver in why their cardiac output and their demand is so high.
And then awake ECMO, before you intubate these people at all, what is your feeling on that, your experience with that, your wisdom on that, if you've had that experience?
Yeah.
Because we're seeing more and more of that at this point in time.
Yeah. We don't do that. We don't. We have a very rigid guideline, and as far as who we will cannulate for VV ECMO for COVID-19. We obviously use the EOLIA criteria. Patients have to meet those, and in addition to the EOLIA criteria, we have very rigid contraindications and relative contraindications on exactly who we will cannulate for ECMO. But we do not put COVID-19 patients on ECMO prior to intubation. We don't do awake ECMO, primarily because, you know, last week, at the height of the pandemic, we had 40, 50 patients in the ICU on high-flow nasal cannula, on BiPAP. Who do you pick to put on ECMO before intubation? How do you pick between a 40-year-old or a 45-year-old or a 50-year-old? If all of those patients are on maximum BiPAP, how do you pick who to put on, especially when you have, 40, 50, 60 people in your ICU and you have a limited number of ECMO devices? How do you even decide who to put on ECMO? And a lot of centers are doing it, and I don't know exactly what their selection criteria is, but it just wasn't something that was going to be feasible here, and I've been fortunate enough to work at Vanderbilt, to where we have an extremely very, very good COVID ICU attendings and pulmonologists and just the entire staff that they're very good about managing these patients without ECMO. Essentially, it's even patients that require intubation. The team here is extremely, they do a phenomenal job in getting a lot of these patients through without ECMO. So I think having a great ICU team, and in my mind, how do you even pick, without intubation, these awake patients, like with an ICU full of patients? how do you even pick who to put on ECMO? So we have not been doing awake ECMO. The one time that we did was for a very, very young patient that recently had a heart transplant, maybe a few weeks prior to contracting COVID,
God.
who ultimately ended up in our ICU on max BiPAP, and with kind of a multidisciplinary discussion, we said that for this specific patient, maybe we should put her on ECMO prior to intubation, because she was a fresh heart transplant, and maybe mechanical ventilation is not the best thing for her new heart. So we put her on ECMO, but even that patient, even though we cannulated her for ECMO before she was intubated, she ultimately required intubation just because she could not tolerate being awake, because she had, after we put her on ECMO, she had worsening lung compliance. And when patients' lungs get that stiff, it's not easy for them to breathe and be awake without sedation.
Well,
so even that patient ultimately needed intubation. So.
Some of that drive that we have, that satisfaction, if you will, of breathing comes from the expansion of your chest cavity. And so when you remove that, they still feel, even though they're oxygenated and their
like
CO2s are normal, they still feel oxygen starved.
Yeah.
It's a horrible phenomenon.
And that leads to being anxious, and then the more anxious you are, the
higher your cardiac output goes, and the more you start stress. Yeah, it's a very difficult phenomenon.
And that's exactly what we saw in her.
Yeah. Do you mind if I ask, what happened ultimately?
Yeah, so we ultimately, what you guys described is exactly what happened. Is she was very well supported on ECMO from a number standpoint, but she just had this sensation of not being able to breathe, extremely tachypnic to the 40s and 50s, and ultimately we had to intubate her, and she got an early tracheostomy, but but that patient ultimately ended up doing fine. She was on ECMO for about 60 days, and for the majority of that, she was awake on the ventilator with the tracheostomy. Ultimately left the hospital and is decannulated from her tracheostomy and is doing okay at home. So
well, that's good.
She ultimately did.
I'm very glad to hear that. I'm very glad to hear that, because those are really, in my experience, at least thus far, anomalies. It keeps us going. It keeps us wanting to try. But I am curious, Joey and Dr. Patel, if both of you could address the issue of, what your outcomes are with COVID-19 recovery when ECMO is used. And I don't necessarily think you have to be too terribly specific, but I have a sense of dread. I'm not happy with our outcomes. We have saved some, and if you're one of those people, it's 100% for you. But I have serious concerns about how many people that were unable to get advanced care because of all the resource utilization for the few that we've saved. Have we lost more than we were actually able to save? And it's a real ethical dilemma that we're dealing with.
Yeah, we just had our monthly committee meeting, our ECMO committee meeting, where we go over those numbers. And
Yeah.
what was it?
Yeah, and
50?
yeah. So I will say, when we first started doing VV ECMO for COVID, our numbers were really bad. We had maybe a 25 to 30% survival. A lot of these patients were dying. So and a lot of the reason for that was we were using the same criteria to select these patients that we were using for non-COVID ARDS. For non-COVID ARDS, we really don't have an age cutoff. And yeah, initially when we first started doing ECMO for COVID, we were putting on 55 and 60-year-olds, and since then, age is a big thing. Age is a big predictor of mortality, even with ECMO. And what we've learned to do is we've really tightened our criteria, and we have very, very rigid selection criteria on who we will cannulate for ECMO. And I think partly because of that, our numbers have markedly improved. I think, like I said, initially when we first started doing this, out of the first 10 patients we put on ECMO, 3 survived and left the hospital, so we had a 30% survival. Since tightening our criteria, using different devices and making other changes in management strategy, we currently have probably supported close to 60 patients on ECMO since over the past year. We have roughly probably a decannulation percentage of about 67 to 70%, and I would say probably our total survival to discharge from the hospital is close to 55 to 60%.
Incredible.
Well, we would be, of course, I think that you brought up the operative term, right? The key component here is selection. I would be ecstatic if we had a 25% survival at this point in time, and it certainly would be good. But, selection, it's kind of like location, I think really is important. But we have seen some very young people with the Delta variant that have really just been destroyed by that particular virus. And, I don't know your view on this, of course. I believe that if the primary cause of the ARDS or the respiratory failure is secondary to an inflammatory response, that is reversible, whereas if it is being caused by death of the pneumocytes from viral replication, that is not survivable. But I don't know, without biopsying people, how you can differentiate between the two. Do you have any thoughts?
Yeah, again, not a lot of thoughts. Again, there are a lot of people that are much smarter than me that struggle with this very same question of where is that line of lung reversibility, lung injury, where it's not going to reverse, whereas lung injury that has the potential to reverse. Like if this it presents in an ARDS-like picture, if this is kind of inflammatory process, you're right, it has the potential of reversing. But a lot of it is these patients have lung destruction, not, maybe it's from the initial COVID insult, but a lot of the lung destruction is from secondary pneumonias that these patients have an incredibly high risk of ventilator-associated pneumonias. And partly because of that, what plays into that is the underlying pathophysiology of COVID is these patients get microvascular thrombi in all their vasculature. They get secondary pneumonias. You give them antibiotics, but antibiotics don't work if they can't get to the area that they're treating, and these patients have microvascular thrombosis. They have pneumonias that you can't clear, which ultimately leads to lung destruction. So, and we've seen, we don't know. Our lung transplant team is also extremely selective in who we do transplant for COVID for. We don't do a whole lot. I think we've only done 3 so far, but we've had patients who I personally thought this patient will never recover. He will never come off of ECMO. We've had patients stay on ECMO for 90 days, for 110 days. Those patients have ultimately been able to be decannulated and they've left the hospital. Mm-hmm. So, it's the answer to your question is I don't know. There have been many times where I've personally thought that this patient is not going to recover, they will not come off of ECMO, but they've proven us wrong, and we've been able to, support patients. And like I said, the longest ECMO run we had was about 110 days, and that patient ultimately left the hospital.
We had a similar experience. I think she was 93 days.
Yeah, 93, 95
93 to 95 days, and she did also. And these are the anomalies, as I said. I didn't think she was going to survive. We had so much packing in her mouth and her nose, and she was just exsanguinating from her oro and nasopharynx, and it was just like, please, we've got to stop. And we didn't. We have an intensivist here that was determined we weren't going to stop. We did a CT.
Right. Well, and she progressed to DNR, and really it was just a waiting game, trying to figure out, what we were going to do to get her family here. They were from far away to try to see her because we really thought this was the end for her.
Yep. I tried to get her to you. I tried to get her to you all.
That's right.
I tried to transfer her to you, Joey. I was talking to Matt on the phone actually, and we talked to Dr. Jordan, right?
Hoffman?
Yeah, Hoffman. Yeah,
Yeah,
Jordan Hoffman.
Hoffman.
Yeah, Dr. Hoffman. And tried to get her up there, and there was, because she was Kaiser Insurance, there was all that stuff
Yeah,
going
once she
on.
started doing better, you know, that we thought she needed a lung transplant, and so there were all these hurdles that her insurance company was making for her to be able to transfer out of our hospital that is not a transplant center to our medical center. And so, yeah, you did contact them.
It was crazy. It was just nuts. And
And ultimately, we got her off ECMO and she went home.
She walked out of the hospital. But a lot of our patients that we have seen decannulated, survive, leave the hospital to LTAC, but they're pulmonary cripples. And so are you seeing a lot of that as well, where, okay, yes, they are alive, and life means different things to different people, but if you really were to grade their quality of life, are we really looking at a 55 to 60% or 50% survival, or are we looking at a much lower number who go on to have what would be judged as a reasonably good quality of life? That's a serious question.
Yeah, and you know, for this subset of patients that get that sick, we've had, you know, very honest conversations with family. We let the family know that there's a very good chance that, you know, the patient will never come off of mechanical ventilation, but we just don't know. As far as I am aware of the two patients or the three patients that left on mechanical ventilation after an extremely prolonged ECMO run. One of those patients I actually just recently saw, he was on nasal cannula. So he was off of mechanical ventilation. He had his tracheostomy decannulated, excuse me, and he was fine. So again, I think the answer is we really do not know. Yeah, we can assume that these patients that go to an LTAC there's a good chance that they will be pulmonary cripples, like you say. They will not ever be able to come off of positive pressure ventilation. But, you know, the answer is we really just don't know at this point of time what long-term COVID, especially in these patients that get affected so severely, what the long-term implications and what the long-term outcomes are. We unfortunately just don't have that data yet. And you know, those three patients I talked about, you know, two of those patients are off the ventilator. So we really, unfortunately, just don't have an answer yet. And who knows, you know, these patients that even though they come off of the ventilator, they're still oxygen dependent. And who knows if they will ever come off oxygen. They may in the future, you know, need lung transplants. We really, truly just don't know what the course will look like for these patients as of right now.
Mm-hmm.
I have a quick question just to circle back to a previous subject we were talking about. When you talked about changing your criteria, what, other than age, what were the changes that you made? Because we're really trying to work on a criteria selection modification here too. And we have good ideas of things that we think we should do, but I'd be interested in hearing what you guys decided to do.
Yeah, and you know, that is the whole tightening criteria and looking at potentially who would, you know, be the patients that would benefit the most is a lot of that work, you know, has been done by the great kind of the ICU team here, Whitney Gannon. She's one of the ECMO kind of NPs, NP in the MICU, and she did a lot of the work to really tighten our criteria, and she looked at exactly, you know, a lot of research went into formulating that document. But essentially, so age is probably one of our most important cutoffs. Number two, we look at organ failure. So we really hesitate to put on patients on ECMO that already have, at the time of the consult, if they're in renal failure, if they look like they're going to progress to needing CRT or dialysis. So we look at degree of organs involved. So if it's just single organ failure without any renal involvement or any other issues, then that's, and we look at medical comorbidity. So a patient, a 40, 50-year-old with diabetes, hypertension, coronary artery disease, it's a big deal. and we look at the number of medical comorbidities. At the time of consult, we look at how sick the patient is. Are they on multiple vasopressors? Are they septic? Are they on a ton of vasopressors and inotropes? Do they have any cardiac involvement? We look at, and then obviously the other absolute contraindications are standard, like no malignancy or things like that. And initially, what we've recently also done is we've also have a BMI cutoff. We really are avoiding for COVID specifically, not for just non-COVID ARDS, but we are avoiding putting on patients with a BMI of over 45 is an absolute contraindication for us right now. Because the heavier the patient, likely the higher the cardiac output, and again, it's just one of those things where those patients are at risk of needing dual circuit support, and we just in the setting of a pandemic, it just may not be the most ideal thing to do. But yeah, I think if I had to pick kind of the most important things is one, do they truly meet Eolier criteria? Like, has the patient been deeply sedated? Are they on inhaled vasodilators? Are they paralyzed? And with all of those things, and have they been prone? And with those things, do they still meet indications for ECMO? Is the most important question. Obviously, if the patient doesn't meet an indication, then you should try to manage them without ECMO. But do they meet indication? And then age. We're avoiding, one of our absolute contraindications right now is an age of over 45, and that really has stemmed from the fact that over the past 2-3 months, we've gotten so many consults for patients who are in their 30s and 40s, healthy young patients, that we've had to turn down so many of those patients just because of resource limitations and hospital capacity. So that's where that age limit of over 45 came into play. That was a recent change just because of the influx of these extremely young, healthy patients who were getting very sick with COVID. So that's where that came in. So age, BMI, and organ failure. If they are in renal failure, that is a relative contraindication for us. And at the time of consultation, how sick are they? Are they on a ton of vasopressors and inotropes? Which in that scenario, probably not the most ideal patient to put on ECMO in the setting of a pandemic.
Well, I have just 2 questions left, and I in deference to your time, and thank you so much for being so generous with it, both of you. Our postpartum ECMOs, or patients that have come and have been pregnant, most of them have been between 20 weeks, and we had the one 27 weeks that just recently passed, and they were able to do a C-section. The ones that have not been viable fetuses, they've aborted in the bed after putting them on ECMO. But our survival on postpartum ECMOs is 0.
And we've had quite a few.
And we've had 9.
9, yeah.
9, and it's 0. Do you have any? And these are very young, otherwise healthy women. Do you have any thoughts on this?
No, again, and we really did talk a lot about when we first started doing this in regards to postpartum. So, we had a multidisciplinary kind of discussion with the obstetric team about when we should cannulate these patients and if we should change our criteria or the indications specifically for these patients. Because from an OB point of view, they want these patients to have a higher saturation goal for fetal purposes. They want the fetus, they want the patient's oxygen saturation above close to 95%, which in a sick COVID patient is a lot to ask for a patient not on ECMO. So, to do that, to achieve that goal, the question came up is, should we put these patients on ECMO who may not meet traditional criteria, but should we put them on ECMO to achieve that higher goal for this specific subset of patients? And we ultimately decided, not to really alter our ECMO kind of initiation criteria. Is we still for these pregnant women, the criteria is still the same. Is our initiation criteria still remain the same? Is we typically do ask for these patients to meet EOLIR criteria. Obviously, they can't be prone, but no other thoughts. Again, we've done 5 of these patients, and all 5 have fortunately survived for us. Although the rate of kind of intrauterine fetal demise is very high. Out of those 5 patients, 4 patients had fetal demise, and 1 patient, fortunately, the baby survived, and she delivered after we decannulated her from ECMO. But again, we're still kind of, we haven't changed our criteria specifically for these groups of patients. But the 5 that we've put on ECMO, they've all fortunately survived, and 1 is actually still on ECMO. So I guess I should say 4 have survived and 1 is still on ECMO.
And my last question, and I'm going to be done, is because we sometimes do see right heart dysfunction, which eventually leads to hepatic problems, and we're seeing liver enzymes going up and eventually liver failure, which we try using milrinone and these kinds of things. But what do you think of the Protect Duo cannula as an ECMO cannula? Do you have any experience with it? Have you tried it? Do you think it's even worth trying it? What are your thoughts in order to try and support the RV during these episodes?
Yeah. So to answer, I'm going to preface this by saying I have no experience with the Protect Duo. We just don't. We at our institution don't use that specific cannula for ECMO. So I have very little experience. We did have a patient who was transferred from another institution who did have a Protect Duo, who they transferred him for a lung transplant evaluation. But I don't have any experience with that. And I guess my thoughts are, we've had very, very sick patients with extensive lung injury who've been on ECMO for weeks and weeks and weeks and months. And yeah, if you look at their RV, it's not going to look great. Their RV struggling because of the underlying ARDS. And we've never run into a case where we've had just florid right heart failure from ARDS. I'm sure they can have pulmonary emboli and things like that. But for the most part, when these patients end up on vasopressors and you look at their heart and their RV's not the greatest, it's because of their underlying ARDS and not necessarily because they're going into right heart failure, and that's what their shock is. It's cardiogenic in nature. For most of these patients, the shock is septic in nature, and they have vasodilatory shock from underlying COVID pneumonia and sepsis from another potential bacterial source. But we've never run into an issue where a patient's on pressors and inotropes potentially, and all of that is secondary to RV failure. We've just never seen that. We've not had, even these patients that stay on ECMO for months, we've not seen hepatic dysfunction from any of this. We've personally just not seen this. So I can't really comment on that, but and I can't really comment on the Protect Duo just because we don't use it. But my thoughts are the underlying problem. The reason we're not able to support these patients is because we're not adequately matching their cardiac output with enough ECMO blood flow. The Protect Duo with a 30, 32 French cannula, how much flow can you truly achieve?
About 2.9 liters.
Yeah, and so you're not
it's
addressing
not very
the underlying
good
problem. Yeah, you can't get enough flow to support the sickest of these patients. And sure, it may work for a lot of these patients that get cannulated before they get intubated, who maybe aren't as sick as some of these patients. Maybe you can get away with 3 liters of flow. But for all of our patients, specifically talking about the patients that have ended up on parallel circuits, a Protect Duo doesn't address the underlying problem of the fact that you're not getting enough ECMO blood flow to match their cardiac output.
Yeah, and there's just so many tubes you can put in somebody, right? You can only do so much. Joey, you have any experience with it at all, or when that patient came in, did you find it to be a functional cannula where it was working well enough? Because their argument, of course, is that you have no recirculation. But of course, you're going to have a little bit of TR. You're going to have a little bit of pulmonary valve regurgitation because you got this cannula going through them. But you know, I don't like the cannula, but we're getting some push to use it. But you know, I'm glad you haven't had that experience with not being able to manage the right heart with just medications and pulmonary vasodilators and that kind of thing. But Joey, go ahead. I'm sorry.
Well, no, I'll preface the not having the RV failure. Our ICU team does a phenomenal job at managing these patients prior to ECMO, meaning they do a great job managing so that we don't have to put them on ECMO.
Mm-hmm.
I think I don't think we wait until it's like a Hail Mary type situation, but they take a lot of preventative steps and do a great job at managing patients. So that way, you know, a lot of them may not, you know, ever have to go on ECMO. I can't speak for other centers. You know, I don't know if they just maybe put them on, you know, prophylactically. But yeah, I mean, here, you know, like I said, they do a great job managing, you know, so that we, you know, we don't have to, you know, go down that route. As far as the Protect Duo, I don't have a whole lot of experience with it. You know, we keep, I think we have 2 on our shelf that they may use for a tandem heart, but other than that, no, I mean, we don't use it for ECMO. When we did have the patient come in with it, you know, either way, I mean, one way or another, I mean, it wasn't a terrible, you know, situation. I mean, we didn't have nonstop issues with it. I do know in town, you know, or across town, I think the hospital here uses it exclusively for COVID. And I can't speak for their experience, but that's just what I've been told is that's what they use for their COVID cannulation is the Protect Duo. So, you know, I've heard good and bad. So, yeah.
All right, very
Yeah,
interesting.
and just to,
Go ahead, sir.
yeah, that one patient, you know, you mentioned about positioning, and the one patient that was transferred here for a lung transplant eval, I think the position, you know, as soon as the patient got here, the tip of the cannula was in the left PA. You can see it on CT scan, on chest X-ray, and incidentally, and I don't know if this is just coincidental, but the left lung of that patient was more consolidated than the right lung. Again,
Yeah.
not sure if it means anything or what, but ultimately that patient ended up getting transplanted. He kind of was able to do physical therapy, and he was awake, and obviously moving around didn't happen. And he didn't need a whole lot of ECMO blood flow support. Like, he was on 2 liters of flow with very little FiO2. It was mostly just for hypercarbia. He just needed that sweep. But ultimately, you know, our team here determined that we couldn't wean him completely off of ECMO, and given the way his lungs looked on CT scan, he likely wouldn't survive without a transplant. So ultimately, he ended up getting transplanted and left the hospital.
Did you change the cannulation, or did you add anything, or did you just
No,
reposition
we
it?
just left it because, yeah, we determined that he likely, you know, with the multidisciplinary group, determined that he likely wouldn't recover without a transplant. So we ended up just leaving him with that configuration, and I mean, you know, he was able to do physical therapy and walk around, and stayed on it for about a week and a half to 2 weeks at our hospital before getting transplanted.
Yeah. Well, my final thoughts, and I'd like to get your final thoughts, but my final thought is ECMO is not a cure. It may help buy you some time to find a cure, but it ain't a cure. I can tell you that right now. Joey, your final thoughts?
Yeah, no, I agree. You know, and that's just, you know, one thing that I've picked up from, you know, just being around like outside hospital transports and hearing, you know, Dr. Patel and others, you know, talk to families is, you know, yeah, you're absolutely right. You know, this isn't going to cure, you know, the problem. You know, it'll help buy us some time. You know, it may or may not work. I mean, it's you know, it's really up to, you know, trying to, you know, let those lungs rest and you know, try to recover to a point of, you know, hopefully a potential decannulation.
Yeah, I agree. I think the communication with the family, that's been a challenge because, these families obviously don't have medical training, don't really understand the kind of support that their family members are getting, and they're holding on to the thought that perhaps this is going to be what saves them. And ultimately, it's really, we don't know if it's going to save them or if it's just going to delay the overall process of
The inevitable.
yeah, of what's going to happen to them. It goes back to, is this going to be a lung that it decides to recover or not? And we just can't seem to figure out a pattern for that one.
No, we
Yeah.
can't.
Yeah. Dr. Patel, thank you so much again. Joey, we appreciate so much that you both joined us and gave us so much of your time. Dr. Patel, if you'd like to just close us out with your final thoughts.
Yeah, no, I totally agree with everything you guys said. And that was a learning point for me as an ECMO fellow, who would be the first person that these families would talk to about ECMO. And I try to do my best to explain to them exactly what ECMO is in simple terms as much as I can. But I make it extremely important to make it to them, to help them understand that this is not something that will reverse what's happening with their lungs. Like you all said, it's just a way to potentially give them some time to help their lungs recover. But I unfortunately sometimes always paint a pretty bleak and dismal picture and say that unfortunately they have maybe a 50 or 60% chance of survival. ECMO is not going to cure this. It just gives us time, and it's certainly one of the most difficult things to do is to talk to family and try to explain to them exactly how sick their loved ones are, and that we'll do everything we can to get them better. But COVID's been extremely challenging, and I've learned so much. A lot of everything I know about ECMO likely has been from taking care of these COVID patients, and it's been I've been very fortunate to work with a great ICU team, a great group of perfusionists, and just a great team that's really helped take care of these very sick patients over the past year.
Well, thank you so much. We appreciate you both, and we look forward to having you back on the show again sometime, Dr. Patel. It was a really great presentation. Very, very interesting.
Thank you, guys.
Yeah,
Thank you, sir. All right, we want to take a break?
Yeah, we can take a break.
We'll
You guys
go to
have a
break.
great day.
You guys have a good day. Thank you again.
Thanks.
Yes, please. 5 minutes. Are we good? Good. Okay, and welcome back to Perfweb. We're getting ready to jump right into the. No. Okay, my mic's on now. Welcome back to Perfweb, and this is Perfweb 69. You know, we missed 68.
Yeah, we got to go back
It's
for that.
been crazy. I still have to give that, and I will, I promise. But I'm going to real quickly, we did the Vanderbilt Faculty Forum. That was fascinating, actually. We're going to jump into Journal Club. This is Journal Club number
22.
I don't know, 22.
Mm-hmm.
And then we're going to go into the John Ingram's Knowledge Nuggets. So my opening remarks. Sponsor, of course, is HET. We're hiring. We've been doing really good with that.
Mm-hmm.
We've hired a couple of great people here recently, so I'm excited. We need to hire some more, and we continue to grow as an organization. Please check us out. Reach out to us. We have an interview coming up, as a matter of fact. Is it next week?
Yeah.
Uh-huh. And so we're looking forward to that. Social media, make sure you like, follow, share, subscribe, give us a thumbs up, hit the bell icon on all the social media platforms. Our websites, perfusioneducation.com and perfweb.us. Go to those sites for our schedule and for our library and all of that. Membership is free. You only pay if you need the CEU certificates. Participation in all of these programs has always been free. And we appreciate, you know what, really important, if you go on the YouTube or you go on whatever these other social media platforms are, I think in particular YouTube, please make comments about our videos. Go in there and make comments. I'd appreciate it so much. You can contact us at contact@perfusioneducation.com. We got a call-in number. You want to be live on the air, you can call that number. Check out our MediWeb app. It's $2.99. And I've got perfusionists, and I love perfusionists. Okay, I do. I love perfusionists. But, you know, it has sections for perfusion and ECMO and everything else. Some of our own perfusionists that are making really good money are complaining about $2.99. Look, it's $2.99.
Can we expense it?
No. And check out our podcasts. Okay, podcasts are becoming very popular. Magic told me that we have over 4,000 participants in our podcasts. Apparently, they're really popular. So we're going to have to start doing some and I asked David earlier today, can we do podcasts from anywhere, not necessarily on air where it's video, but just audio? Because, look, I know an awful lot of people I can call, and we can have some really good conversations just talking one-on-one or multiple people at one time because of the way we're able to connect now. And COVID sucks. I don't know what else to say. That's my opening remarks. In fact, can you put that up? COVID sucks.
Let's stay positive.
COVID sucks. Really bad. It has destroyed my life. And,
I wouldn't go that far.
Okay. It has demoralized me because I have watched a lot of lives being destroyed. That is very true. And it has really affected me. So I'm going to turn this over to Tammy. This is her journal club. I was trying to eat my keto snack, but she said run the intro while I was trying to open it up. So you can put the camera on Tammy, and she can start with the journal club, and I'm going to eat my keto snack. Oh, by the way, welcome, John. I saw him over there. I didn't see that he was already online. John, how are you today? It's good to see you.
Good morning. Coming to you live from beautiful, sunny Key West, Florida.
Oh, you're in Key West?
Wonderful, John.
Yeah, I was wondering
Welcome.
what happened to your library that's behind you, the fake library that you always sit by, and with the big leather couch.
Yeah, well, that's my Orlando office. So we're down in the satellite Key West office at the moment.
Well, good for you. Good for you. Welcome, and it's good to see you. I'm looking forward to hearing about the knowledge nuggets on the Factor 7. I know that we've had a couple of circumstances here recently where I thought we were going to be given some factor 7, but we didn't give it. So I'm very interested to hear about this. That's a provocative topic, so I'm glad you picked that. Okay, David, go on to Tammy so I can eat my keto snack, and let's get this Tammy, the Sparacino Journal Club rolling.
You know, we've tried to go a couple times, but you won't stop talking.
Okay, sorry.
Welcome.
Turn my mic off.
Welcome, John, and welcome to everyone who's joining us for the Journal Club. Today, the article that we are going to be looking at for Journal Club is from Perfusion. It was published in August of 2020, and the title is The Early Experience of Pump-Controlled Retrograde Trial-Off for Weaning from Veno-Arterial Extracorporeal Membrane Oxygenation in Adult Patients with Cardiogenic Shock. And you can see it's by Min Ho Ju and his colleagues. Okay.
And me, him, Lim.
Oh, Joe? Here's the abstract. So a little bit of an introduction, because I actually was not familiar with this technique at all. So I found this article really fascinating, and I think it might be really interesting to you as well. So pump-controlled retrograde trial-off has recently been introduced as an effective method for weaning VA ECMO in pediatric patients specifically. However, studies on pump-controlled retrograde trial-off in adults were lacking. So this study aimed to examine the outcomes of pump-controlled retrograde trial-off for weaning VA ECMO in adult patients. And you can see that their methods were between January 2018 and July 2019. They actually had a good amount of patients. They had 87 consecutive adult patients that underwent VA ECMO, and 47 of them, or 54%, underwent the pump-controlled retrograde trial-off weaning from ECMO, and they were enrolled in this study. The trials were, the trial-off's results were, a reapplication rate and clinical values were analyzed. Results of the 47, 38, or 80, basically 81%, were weaned from VA ECMO, and sorry, lost my place there. Weaned using the trial off, and then 5 were weaned. They were weaned on the first attempt. 5 were weaned on the second attempt, and 4 on the third attempt. 3 of the patients were converted to VV ECMO, due to desaturation, but had stable blood pressure during the pump-controlled retrograde trial off. No ECMO reapplication was performed within 3 days after removal. 2 patients underwent VA ECMO VA ECMO during follow-up. No complications associated with the retrograde trial-offs occurred, including any thromboembolic events. 5 in-hospital deaths occurred after weaning, and their total conclusion was that this method for trial off is an effective method to safely wean from VA ECMO in adult patients. They find it to be simple and easily implemented without additional invasive procedures, and may help prevent deterioration of the cardiovascular system after weaning from VA ECMO. All right.
Okay.
Is that a lot?
Are you fixing to tell us? No, that's okay. But
Yeah.
Are you fixing to tell us what exactly this is?
Yeah.
Okay.
That's
good.
what this article is about.
Okay.
So here we go. Okay, so why this paper was published. We touched on that in the abstract, but this group was very interested in applying this type of weaning technique in their facility, and then publishing a paper about it, because although there were papers published about it, they were mainly in the pediatric population, and this technique had been being used in some adult populations, but not a lot of literature out there tracking the success of it. What they did was they just decided to do this study, record their results, and see if it would be something that they could reproduce and then be able to share it with others for the exact same purpose. So here's their methods and procedures. So if you want to take a look at this image, you'll see that normal VA ECMO flow is shown on the most left side of the screen, and you have, just your normal drainage running through the ECMO pump and then return. They happen to be using femoral cannulation here, but of course there's other variations for that. Then in the center, you'll see that this is what they call their backflow test with a partial clamp. So what they do is the whole concept is that you turn your RPMs down low enough that you get retrograde flow from the arterial side, so that then you are flowing instead of returning on the arterial side. You are flowing from the patient from the arterial side in the reverse through the ECMO circuit, then back in and being returned on the femoral side. You see that?
Oh, yeah,
Okay.
I see it.
Okay.
But they're using tubing clamps, and they're not using screw clamps. We need to discuss that.
So the center diagram actually shows them just inhibiting the flow enough so that they're able to be able to control how much backflow they get. So it's kind of a protective measure. Then the diagram all the way to the right is what they actually call the PCRTO, which is the pump-controlled retrograde trial off technique. And I found it really fascinating. First off, have you ever heard of this?
No.
John, have you ever heard of this?
No, I have not. I'm absolutely stumped by this. But
Yeah, it's pretty interesting. Okay, so let me just read, now that I've kind of described it and you know what we're talking about here, let me just read their description for the figure. So they say, Figure 1, physiological changes during normal VA ECMO and pump-controlled retrograde trial off. In the diagram A, peripheral femoral or FEMFEM VA ECMO circuit is connected to the patient in the normal forward flow. In figure B, retrograde flow is established. Oh, yes, that's correct. I didn't explain that. B, the pump is actually off, okay? And they use the clamps to control so that they can control the exact amount of retrograde flow. 2 partial clamps were applied on the arterial cannula to control the amount of the backflow shunt. Then in C, they have the retrograde flow established during the pump-controlled retrograde trial off with the patient still connected to the circuit. The amount of backflow was controlled by the ECMO pump, and there was no additional circuit connection. And I'll explain how you do that, but it's really quite fascinating because they're right. You really don't change anything at all to the circuit to be able to see if the patient is going to be able to tolerate coming off VA ECMO.
Mm-hmm.
Yeah.
But you're also providing some, I'm assuming, because you're creating an AV shunt, you're creating some increase in your venous saturation going
Yes.
back to the lungs.
Yes.
But doing it by using the left-sided systemic pressure to just drive it.
Yes, exactly.
Mm-hmm.
Exactly. Okay, so here's figure 2. Just kind of breaks down some of the numbers that I gave you in the abstract. So again, this was done over about a year. They had at their facility 207 adult ECMOs, so they have a pretty good size number.
That's pretty damn busy.
Yeah. They the exclusions were if they were VV or if they were VA, simply for lung transplant. And the ones that made it into the study were 87, so it was VA ECMO just for circulatory support. And they had 48 that they were able to wean from ECMO, 39 that did weaning failure. The ones that weaned from ECMO, only 1 did not have the backflow test. 47 of them had the backflow test. And the reason the 1 did not is they had a LV thrombus removal for some reason in the operating room. The weaning failure ones, 10 went to transplant and 29 died. Okay, so just a real quick look at their patient characteristics for their ECMO. You can see that they looked at all the normal parameters. you know, the body weight, the height, BMI, the reason for ECMO support. Overwhelmingly, you can see it was a ischemic heart disease, but they had other reasons for cardiogenic shock as well. Their average duration for their ECMO for this purpose, 4 days. Awakening ECMO without a ventilator, 9 days. They had 2 types of ECMO circuits that they used. One that's the McKay permanent life support, and then one that is the Terumo emergency bypass system. Didn't seem to really have much difference in those, just what they had available. They show their cannula sizes, distal perfusion, etc.
These are some pretty small patients because a 16 arterial, I mean, is pretty small for VA ECMO.
Yes, yes.
Depending on the size of the patient. I mean,
Sure.
that's what we did here recently when we did the VA, we used a 16 because I didn't think she needed, you know, big high flow arterial because I'm splitting it now. But we had problems with that. But a 16 is pretty small. So what's the BMI on these patients? 24. So yeah, they're small patients.
Yeah, they're pretty small, average, within a healthy weight size.
I mean, 65 kilograms is the normal birth weight here in Houston.
And this study took place in Korea, so some of that also may just be
North, where they don't eat. No, south.
Some of that may just be cultural differences in what their patient population they have there. Then you'll see that a few of their ECMOs they had to modify and go VVA and VAV. Okay, so here's their flow chart for deciding when they could do this pump-controlled retrograde trial off. So step 1 would just be they think they're ready for VA weaning. Step 2 is ECMO, flow is decreased to 30%. Their backflow, a shunt test, is initiated, and they go down by they determine the backflow at 10 milliliters per kilogram is what they estimate that to be. Okay, and then
that'd be 600 cc's.
Yeah. So then, if they go through all of that, then they're able to do the ECMO removal. Now, unstable vital signs. So anything less a systolic less than 90. If they have any arrhythmias, if they have any increase in lactate, any progression of acidosis, and then their backflow test, they will do a daily echo follow-up. They'll do low-dose catecholamine, and they have to be under heparinization with a PTT greater than 70 due to the low
That did
flow.
not surprise me.
Yeah.
I was actually.
You were waiting for that?
I was waiting for something because I'm going to tell you what, that would scare me.
Yeah, for sure. Okay, so here are the profiles and clinical outcomes. So as we touched on earlier, primarily, most of their patients were successful on the first attempt, and they had a few that had to have a second and 4 that had to have a third attempt. They, 3 of them, they had to change to VV ECMO because after the VA support, they needed a little just respiratory support, and they had 0 thrombotic events. They had no reinsertions of VA ECMO within 3 days, 2 after 3 days, 0 VV reinsertions. In-hospital death after ECMO removal was 5. Their average intensive care stay was 12 days. Their average hospital stay, 37. Other hospital referrals, 12. And their home discharge, 30. So not bad. All right.
That's about right. 40%. You're saying 40% survival, 38% survival. Can you go back?
Yeah, I'll go back. Well,
Number
no,
of
63.
attempts.
Yeah.
So 63%, which is much higher than usually stated. VA ECMO is generally quoted at about a 40% survival.
Yeah, I'll
right?
get into those numbers a little bit later. It's actually widely varied, just depending on what published study that you look at.
Agreed. Okay.
Yeah. But they had pretty good results, 63, almost 64%.
Mhm.
So their flow parameter during these trials. So let's see. On the PLS, again, that's just the McKay system. Here's 2 points that they look at. First, they determine what is your zero flow point. In other words, what's the exact amount of RPMs that you need to apply that you don't get forward flow and you don't get reverse flow. So that's something they tracked. And their average was 1,500 RPMs. And you can see the range was between 1,200 and 1,780.
Yeah, that's just going to depend on systemic vascular resistance.
But
and the design of the pump
But no, just hold on.
Okay.
Just hold on to that. Then the RPMs to initiate the retrograde flow, you can see their average was 1,300, and with a range of around 1,100 to 1,500. Now on the other system, again, they had to do 2 different variables since they had 2 different systems. The RPM zero flow point on the EBS was 945 with a range of 780 to about 1,500, and then the RPM needed for the retrograde flow was 745 with a range of 700 to 1,300. Let's see. Those were all the successful weaning. Now, at the ones that were unsuccessful at the weaning, whether that be the first or second attempt, you can see that the PLS, they had 2 of them, and the range was 1,200 to 1,400. And with the EBS, the 0-point flow was 710 to 850. And what they talk about is they were trying to see if there's any correlation with success with where you are for 0 point and fail. And what they found was, and you'll notice here, is patients that had a lower RPM 0-point flow, so it depends on what's going on with their systemic vascular resistance and pressures, those were the ones that that failed weaning. Now, they couldn't find an absolute number because, of course, that's going to vary, but it's just something that they noticed.
So the higher your RPMs were, and because
Average.
your cardiac output was average,
Yeah.
because your cardiac output was better,
Yes.
the easier the systemic circulation would overcome the pump.
Yes.
So the lower you had to go on the RPMs, the weaker your systemic
Exactly.
circulation was, the more likely you were to fail.
Right. Exactly.
Okay, I got it.
And
I got this.
That's why I thought it was it was an interesting way to look at it, to determine the 0-point flow. All right, so let's talk about their conclusions. Very simple conclusion. They found that this method is an effective way to identify the reservoir of the heart function using overloading in the cardiovascular system, particularly in patients with marginal heart function. It is simple and feasible without an invasive procedure and showed good outcomes for weaning from VA ECMO. All right, so do you want to have a little brief panel discussion about this before I go on?
No, I want you to go on because I want you to go on.
Okay.
I need you to go on with this.
You need me to go on?
Because there's got to be a point to this.
Well, yeah.
Okay, well, please.
Well,
What would you like to do? It's your show. Do you want to discuss this, or do you want to?
yeah, I'd like to discuss it because my next one really is more generalized and not specifically about this article.
Okay, John,
Yeah.
I'm going to let you start this.
I have, this is very fascinating, never seen anything quite like this. But I have 2 things I like about this and 2 things so far at the moment I'm not terribly fond of about this. It's very fascinating. But if you go back to about the middle of your presentation and there was a patient parameter slide, you pretty much showed all of the
demographics?
There you go, yeah, right there. So you can kind of tell this was done in a country where it's not Texas, I can tell you that, right, Joe?
No, I told you the birth weight here. 65
I guess,
kilograms is
Well,
our
but-
birth weight.
But I think he was talking about
Well-
that they only list males.
Well, I'm
Oh.
looking at the weight, the age and the weight of the patient. So if you look at, what was it, Hong Kong, I guess you said?
No, Korea.
Korea.
Okay, so, just culturally, you have very minimal obesity, and especially in the elderly population. So if you look at the age of the patients, almost 58 years old, plus or minus 16. So you have the elderly population, which generally in those countries is pretty well, slimmed down. And you see that in the BSA. So that's number one. And I think that actually helps here compared to some of the things that we may see in our country. But if you also look at this, what year was this published, Tammy?
This was published last year, 2020.
Wow, even during COVID, because they don't seem to have COVID patients on here. So you're looking at all cardiogenic patients.
Yeah, this is strictly cardiogenic patients, correct?
So what's interesting is that if you have cardiogenic patients and you look at the duration of ECMO days, 2 to 7 with a mean of 4, this tells me that, a lot of these patients were pretty acute and just needed a few days of rest, and then they came back and their hearts got stronger with that rest, and then they were able to have quite a bit of success, as high as you said, 64%.
Or they revascularized them, since most of them were ischemic.
Yeah.
Right? So they put them on VA ECMO. They took them to the cath lab. They opened up the culprit vessel or vessels, and then
They don't really talk about that.
they had to do. I mean,
Yeah.
well, I'm assuming they did something with them.
Yeah,
If it's
they don't
ischemic,
say.
Mm-hmm.
They don't say.
They don't say.
if you just have a big MI, you're probably not going to recover.
Yeah.
Now, the myocarditis patients were probably a little bit more sticky, and maybe the heart failure patients were a little bit more sticky too. But you could still, take a lot of volume off, dry their lungs out with the heart failure patients. You could definitely work on the arrhythmia problems while you're on ECMO. So I think their success, large percentage of their success, and the reason it was so high on VA ECMO had to do with their patient population, but also the fact that they were able to treat these heart conditions over the only 4 days on ECMO. So apparently they were able to correct a lot of these patients' problems. But as far as the technique goes, two things that I like about it is that it tests the patient's cardiac output plus 10%. In other words, if you have a retrograde flow of 10 milliliters per kilogram, and you said, Joe, it comes out to 600 cc's a minute, that's roughly 15 or so % of the cardiac output that is being shunted AV. So the patient is having to support themselves systemically plus a 15% or so AV shunt that is not supported there systemically, except they are getting some VV benefit essentially, right? Because they're getting oxygenation to their venous side that they normally wouldn't have, but they're losing the perfusion benefit of the cardiac output by doing that.
Yeah.
So that part tells me that not only is the patient ready to come off, they're more than ready to come off because they're losing 15% of their cardiac output through this shunt. But the thing that I don't like about it so far is that if you only have 600 cc's per minute or less going retrograde through a circuit, you have very serious concerns about clotting, and I'm sure that's why they did a PTT of 70 or greater, but I still have pretty grave concerns of that slow of a flow going back through a artificial circuit. So that's one thing I'd be a little concerned about, but I guess they didn't. Did they talk about their complications with that?
Yeah, they had zero clot complications. So
Yeah, they didn't have to. Well, I mean, their PTT was greater than 70.
yeah.
So I mean, if your PTT is 110, you're not going to clot the circuit at 600 cc's of flow. I'm just trying to understand why.
Well,
Did you
read the article?
No.
Okay.
That's why you're here.
Okay. Well,
So tell me why.
What I got from it is they use it as a method to avoid early decannulation and then having to recannulate, because they talk about that a lot, that they had no reinitiation of ECMO. So without changing anything, without risking anything, having to remove your cannulas or trialing off, and then your circuit clotting, you're having to use a new circuit. That's what I got from it.
So, okay, and I understand that. I do, and I appreciate. I really do. I appreciate doing this study. I remember when we picked it.
Mm-hmm.
I actually think I picked it for you.
You did.
Mm-hmm. So I threw you under the bus. But
I thought it was interesting.
What's the difference in flowing 600 cc's? If it's 600 cc's, and that's what they're saying with a PTT greater than 70, you don't have to worry about clotting the circuit out, whatever. What would be the difference? Although the difference is you don't lose 15% of your cardiac output by going retrograde, right? But if you turned your flow down to 600 and you just flowed at that level and looked at your blood pressure, your inotropy support, all the various things that you would look at, and left them there like that for some period of time, I mean, once you decannulate, right? So even if they succeed in the retrograde trial off period, and you decannulate, when you decannulate, you've decannulated. So if you feel you can decannulate predicated on these numbers, but you're flowing 600 cc's as opposed to backwards, but just forwards, and your inotropy support and pressure support and every other support is not unusually high, it's appropriate to decannulate. I just don't understand where the benefit is coming from. Like, I can't quite get what it is. That seems really difficult to do because your SVR is going to be constantly changing, and you set your RPMs to a certain level, and you have your flow probe on, and you'll say you're getting 600 cc's backwards, but your SVR drops, and then you're going to have less coming through, or your SVR goes up, and you're going to have more going through, and it just seems like that's very labor intensive rather than just setting a flow somewhere between 500 and a liter, either with clamps or reducing your RPMs or whatever it may be, and I don't see any increase in thromboembolic risk because you've got your arterial flow is just going to be passing by the cannula. You're very well anticoagulated. The venous will be flowing just like it would be normally if you were flowing backwards through it or not. I don't know. It just doesn't seem to make sense to me. I just don't understand it.
Well,
I'm having a hard time with this.
I think what I can say about that is it's kind of like saying, Tammy, you're a runner, right? If somebody said to you, in order to qualify for this particular run, you have to be able to run a 5-minute mile, but you know that you can run a 4-minute mile. So you have no concern about running this run and making sure that you get it done in under 5-minute mile. And I think that's what they're doing here. They're adding 10% or 15% maybe at least, or maybe more on some of these small patients. 600 cc's a minute on a very tiny patient might even be 20% of their cardiac output. So I guess if you can perfuse yourself and in addition to another 20%, you certainly can be weaned off ECMO. So I wonder how long do they try this for, though? Do they do it for 24 hours or just a couple hours? Or because you're talking about fluctuation.
Yeah, hold on. Let's see. They did talk about that. Joe, see if you have any more comments, go ahead, and I will.
No, I hear what you're saying, John. I think that what you're saying is that they are challenging.
Yes, that's exactly what I think they're doing.
And in that regard, of course, if you're challenging the patient and they need, let's say, I'm just going to throw some number out there. Let's say they're on 5 of Trex, and they don't have any increase in their Trex need for having looking adequate enough to be decannulated. So if you had 600 cc's a minute going forward and you didn't need any Trex at all, wouldn't it be the same thing? I mean, to me, it doesn't it doesn't make sense to add a burden to a recently negatively impacted cardiovascular system by taking 15 or 20% of their cardiac output and making them work that much harder. But of course, they measured lactates, and if they had a bump in lactate, they abandoned it, or they had any kind of acidemia, acidosis occurring, they took care of that. So they did examine those things. They looked at those things, but this, I don't know, would you do this? Would you recommend this to any of your guys?
I've never heard of this before, so it's hard to say. I think
Yeah.
they'd probably all be a lot of eyebrows raised, just like me and you were doing when Tammy was first going through it. But I think that the patients are more than ready to come off.
Yes.
And when you add an additional 15% burden to essentially what they're doing, with the exception that you're having some higher venous saturation because of it. But cardiac-wise, you're adding an additional burden. So if they can handle the additional burden, they can certainly handle it on their own. So I guess it's a pretty good test.
Yeah.
Of the hearts that have come back.
Did we lose our internet or anything?
No, I don't think so.
No? Oh, okay.
Yeah.
My
Yeah.
computer went crazy.
Oh, okay.
I'm sorry.
Yeah, I can't find that data, John,
Well,
but
That's all right.
What I was wondering too, though, is why do they have the clamps step? Why do they do it with clamps first? In other words, if you're flowing forward at 2 liters a minute, if you're ready to do this retrograde trial, why don't you just gradually decrease your RPMs until you get to zero flow, and then continually decrease it until you get to your retrograde flow? Why do you have to go through that clamp step first?
I believe the clamp step was their initial way of trying this out.
Okay, yeah.
Yeah, when they were starting this
Oh,
protocol.
so they turned in the beginning, they turned the RPMs all the way to 0.
Yes.
And then used a clamp to modulate the retrograde flow.
Right.
Versus they
hadn't figured out the zero flow thing yet. It was
the
a
RPMs,
process.
Yeah. I wouldn't want to be the ECMO manager, ECMO technical manager on that case, because that just seems like it's going to be very busy.
Well,
Yeah.
At what point do you take your flow probe off the line and reverse it so it's not alarming like crazy?
Yeah.
Yeah.
Exactly.
No kidding.
Exactly.
Okay.
Well, let's move forward.
All
Okay,
right.
That was a good discussion, interesting talk.
All right. So let's move forward with a little more talk about VA ECMO.
That's great, because you know what? All we've talked about is VV ECMO and
I know.
COVID.
I was so excited.
And I'm sick of VV ECMO and
I
COVID.
almost put something on here, and surprise, ECMO, but not VV and not COVID.
That would have actually been funny. I would have liked that.
Okay, so we're just going to talk about, and we've talked about this in the past, but there are a few things that actually I learned when I was reading some articles on this. So we're going to talk about some considerations for weaning. I know this isn't your favorite source, but I actually found some really interesting information in this article. So this is from the Annals of Cardiothoracic Surgery.
Well, I don't dislike that.
Well, I know, but it's a summary kind of thing. But
Oh,
for what
okay.
I need it for, it actually worked quite well. So this was published in January 2019. Weaning from VA ECMO, what strategy should we use? And you can see a primary author, Ortuno, I believe, is how that was.
Sophia.
Yeah, Sophia Ortuno. All right, so I just read through, the summary of everything that they sort of found in their literature research, and this is what I came up with for VA ECMO cardiogenic shot. So, of course, the purpose is to bridge to myocardial recovery, either partial or full, bridge to transplant, or bridge to bridge. Weaning, and here's those crazy numbers. Successful weaning ranges anywhere from 13 to 76%, and it depends on the underlying cause. Survival to hospital discharge, 20 to 65%, will actually die before discharge. Predictors of mortality after weaning: diabetes, obesity, the door to VA ECMO implantation time.
That's why you see them doing it now, like in Paris,
Yeah,
where they're
the
actually
ECPR.
the ECPR in the field.
The CPR duration, poor renal or liver function, high lactate levels, and high.
SOFA scores.
Yeah, I was going to say, I'm assuming you pronounce it SOFA score.
Yes.
Okay, so I actually have heard of that, but didn't know a lot about it, and so I get into it just a little bit here for anybody else who is with us who doesn't know a lot about this. So I knew that a high score was bad, and I didn't really know how you got to that. So if you're not familiar, the SOFA score has to do with sequential organ failure assessment. It was developed in 1994 by the European Intensive Care and Emergency Medicine at a consensus conference. It originally was named the septic organ failure assessment, but then they figured out that it also can apply to non-septic patients, and so it's become a pretty common tool in just kind of looking at the progression of these really sick patients. It looks at 6 systems: respiratory, coagulation, hepatic, cardiovascular, central nervous system, and renal. The scoring is normal function of any of those systems would be 0, and then the most abnormal would be 4. The worst values recorded for each system for every day. So even if you have that one really bad value in that day, that's the one you have to record for this system. Organs are monitored individually over time, but you can also look at an overall score to be calculated. Okay? And here is the scoring system itself. So you can see that you've got 0 all the way to 4, so 5 categories there. And these are the ranges that they look at for the individual categories, whether it be, you know, what your FiO2 is and your oxygen PaO2s, your coagulation in that. What are your platelets? What's your bilirubin? You know, what's your MAP? Are you on, you know, any pressors? What's your CNS score? And they look at the Glasgow Coma score, which I don't know a lot about that, but it basically has to do with following commands and such. And then your renal, they look at your creatinine and your urine output. And just for fun, I thought since we love to do these interactive things, I thought we would go ahead and try to calculate a SOFA score. So how do I make this work?
Click it.
Okay, there we go. All right, so there's a lot of different websites out there that calculate this, but here is one that I found that I thought would be easy to see on the screen. So we'll just go ahead and, do you want to make up one or you want to do a sample one?
I'll make it up.
Okay, so tell me, what is our patient's...
FiO2, they're on the vent 100%.
Okay, I think I have to use a keyboard for this, so let's see. Oh, hold on. Okay, and what's their PaO2?
We'll make them a COVID patient, so we'll give them a PaO2 of 768.
Okay, and they're
Yes.
Yes, they're on mechanical ventilation. Oh wait, hold on. I gotta go. Oh shoot. Yes. Okay. Then.
Oh, you have to get rid. Oh, okay. You have a period
Yeah, I
there.
have to go back. Yep.
Platelets. Well, you know, we'll give them 150,000
Okay.
normal. So 150. Yeah.
All right. And then, let's see. What is their bilirubin?
We'll give them a bilirubin of 2.
Okay. And what's their Glasgow Coma score? I think a really high is like 15 or 16.
Yeah, it's we'll say they're awake, alert. There's no issues.
Okay. So we'll give them like let's give them a 4. Okay. And then let's see. And what's their MAP?
70.
Okay. And are they on vasopressors?
No.
No vasopressors. Okay. And what's their creatinine?
1.2.
Okay, and then what's their urine output? The choices are greater than 500 milliliters per day, 2 to 500, or less than 200.
2 to 500.
Okay. Oh, wait, hold on. All right, now are you ready?
I'm ready.
Calculate. Okay, so the score is 14, And you can see that their estimated mortality is 50 to 60%.
And that's a reasonably decent patient that we get.
Yep.
That's not a bad, I did not make that horrible, other
No.
than their PF ratio.
But you'll look here in the little summary
Mm-hmm.
that where your negative points came from. So
Well, why, if they're normal neurologically, why did we give them, they're getting 4 points? Why? Because they shouldn't be.
did you want them to have a 1?
Well,
here?
no, it says less than 6. So I'm not sure how you score the coma score. What's better? What's worse? I
Okay,
think I would
hold on.
make it normal.
Let me show you.
What's
let's see.
normal in that? So I have to look that up.
Yeah, it's right here.
Oh.
So you can look at normal would be, it's supposed to be higher, not lower. I got that one backwards.
Yeah,
Okay,
so
so
give
they
'em-
had a pretty low
So
one.
give them 14.
Okay, so, I have to do it all over again.
Oh, that's all right. 100,
Okay, hold on. 100, okay,
68,
68.
yes,
Yes. What did you say for that, 100?
120, 150.
Uh,
It doesn't matter.
Okay. And then their bilirubin was
2.
2. And then, so this should be
14.
14, yeah, sorry. And then that was 70 and no pressors. Creatinine was
1.2.
Okay. And then they were kind of in the middle there.
250 to 500.
Okay.
11.
Okay. So,
Still a very high mortality.
yeah.
So let's give them better urine out. Can you just change the urine
Yep.
output? Let's make them greater than 500 a day and recalculate it.
9.
9. So that look at the difference
Yep.
in the mortality. Went from 40 to 50 to 15 to 20 just off of that.
Yeah.
And I'm just curious, can you make their creatinine 0.9?
Yeah. Say
It
about the
didn't
same.
change the mortality, but it lowered their points.
Yeah, but let's do something else here. Let's just go ahead and do the thing that is usually a thing, right? So let's just say they're on just very, very small amount of something. You see what just that one thing did?
Yes.
Because I played with this a little bit last
Yes,
night.
that's frightening.
Yeah, can you imagine if we had, all of those? I just put a pretty small amount,
Yeah.
Yeah.
I'm curious. So let's try this. Let's change
Well-
the.
Oh, John, do you have something?
Yeah, so I mean, this is unbelievable because basically what you have here is a patient on 100%, which is very common for us nowadays. PO2, a lot of times it's less than 68, it's more like 50, 55. But you have 68, and they're all on pressors pretty much. So
Yeah.
any pressors at all, they're all, this ventilator setting is so common. Everything else is good Glasgow, good bilirubin. But if you have a poor urine output, probably means they're leaning towards renal failure. Maybe they have to be on CRT. It didn't like that at all.
No.
And as soon as you put any vasopressor on there, it just skyrocketed. So when you
Mm-hmm.
combine the poor ventilatory status with a little bit of vasopressor, apparently you're in a pretty bad zone, and we see that every single patient. I think.
Yeah, well,
Yeah.
let's make this
Oh,
a little
can you
more
do me
realistic.
one? Yeah, do that. But I want you to do one other thing after you've done it.
Okay. What else?
So change the norepi
Yeah.
to what we just saw on
Okay.
our patient to 50 mics per minute, not
minute, yeah.
mics per kilo, but 50, and then mics per kilo. Yeah. Now calculate it.
Oh, I need to know their weight.
Their weight is
70?
no, I think she was more than that. She was, I think, 85 kilos.
Okay.
It didn't really make that much of a difference.
I haven't calculated it
Oh.
yet. Oh, yeah, no, it didn't make that much of a difference. I guess because if you're on one,
Hit the no, you didn't. Oh, okay, yeah, 50.
yeah.
So
So if you're on it, it automatically puts you in a new category.
click calculate one more time. Yeah,
Yeah.
it didn't make any difference.
Yeah, I think it matters if you're on it at all. Let's go back to the PowerPoint real quick because I think it says something about that. So, cardiovascular, if you're on any dobutamine, it doesn't matter the dose. And look, norepi or epinephrine, even at the smallest amount,
Pushes you to 3 and 4.
yeah. So it's almost like it doesn't matter. You're just going to your max of what you can. But as soon as you even have that, it puts you in the most abnormal categories. Yeah, it's pretty interesting, I thought, because I really didn't know a lot about this. Have you played around with this much?
No,
Yeah.
no, I have not.
Yeah.
I know that a high SOFA score is bad.
Yeah, that's all I
kind
knew.
of knew what it was.
Yeah.
But no, I've never really done SOFA scores to do it.
Yeah. Well, now if you see one, you'll have a little bit better understanding of it, I hope.
Absolutely.
Okay,
Yes.
so in this article, they talked about factors to assess for successful weaning. And they were really specific in saying that lots of authors, the ones specifically in this table, have tried to find things, but they were really more observational, and they could not find an absolute range on any of them. But here's some of the things that they looked at. Pulse pressure, biomarkers, echo, hemodynamic assessment while weaning, and microcirculation.
You know,
I knew that was going to make you happy.
it does. No, it doesn't just make me happy. I just wish that we would be more, I think, like that lady that I'm just so, troubled by. I think it would have been important, and maybe it would have been academic, but I think that if you have such an incredibly obvious microcirculatory derangement, it helps guide, your decisions and what to do.
Well,
I know we can eventually get the markers for it, the biomarkers, right? Your lactate levels go up. I mean, there's obvious things that are going to happen, but so much of what we do masks so much of what's actually happening to the patient because we have so much technology.
Well, and if we just go back to just real quick about what Dr. Patel, I mean, I could have talked to him all morning, but
Me
I
too.
imagine he needed to get to doing his actual work. But going back to what he was talking about, even in just talking about COVID patients and the microcirculation within the lungs, I hadn't even thought about this, that if you've got a secondary pneumonia and you're giving antibiotics for it, but if you have no microcirculation, how are you ever going to get to the root of the problem?
Right.
You're not.
Right. And then those lungs just liquefy.
Right.
They just die.
Yes.
And they become eventually just scar tissue.
Correct.
Yeah.
Anyway,
But then that didn't happen to Michelle.
well, and we just don't know why, though.
I know.
She's a miracle.
I don't understand. I mean, I don't understand. I mean, yes, it is. She is. But again, I God bless her and God bless those patients who have survived this horrible disease. But, I'm very troubled with that at what cost. And I think that they clearly said, I don't know what you're seeing there, John. I mean, I'm curious to know what y'all are doing. But, when you are throwing everything that you have in the kitchen sink on top of it at one patient, you have a whole bunch of other patients who don't have access to that. And I don't know what the right answer is. I don't really know.
Well, and even if we could get into a huge ethical,
quagmire.
Yeah, and we could get into a huge ethical discussion about just what Dr. Patel says, who gets it and why.
Yeah.
Because we have patients that, some we're doing every single thing for despite them not being the best candidate, and others that they're also not the best candidate, but why not them?
Well, I got a telephone call. I have to tell you this. We got a telephone call in the unit the other night. And, I guess it was no, it was not at night. It was the weekend, but it was in the afternoon. I'm sorry. It was in the afternoon on the weekend, Sunday, I think. And we got a call from a hospital, we believed. The nurse said there's a hospital on the phone, wants to know if we have an ECMO pump that we can accept a patient. And we, finally got somebody else to talk to the person calling. We're like, we got to escalate this up. it wasn't a hospital.
Yeah.
It was the patient's family
Yeah.
who had made their way through the telephone system to get directly to the ICU and was trying to get their family member moved from another hospital that didn't provide ECMO to ours. And
Well-
we didn't have anything, we had nothing available. We had no way to accept this patient. Plus, you can't do it that direction. You've got to go through
Right.
the proper channels.
Well, and I'm going to comment on this, and this might seem like a joke, but I assure you it's not. In some of my perfusion groups that I belong to on social media, you know, where we discuss various things in there, someone was monitoring a different social media site and found where a person, a non-medical person, had placed a, you know, a query, a solicitation kind of thing on a social media site, asking for where to purchase an ECMO pump that they could use at home.
That's frightening. It's very frightening.
I mean, the title of it was, by the time it got through, was "Perfusionist Not Included." I mean, but that's where we are. People are so desperate
Yeah.
that they really just don't even understand. Well, let me
Yeah.
get through my last slide here, and then we can have some more discussion. I don't want to run into John's time because I'm sure his knowledge nuggets is going to be awesome. Okay, so this, then the annals came up with, after they looked at all the literature, this is their summary of what the strategy is that they recommend from the literature that they reviewed on how to wean VA ECMO. So you'll see that they've got a proposed algorithm here for successful weaning of VA ECMO. So they're going to look at the mean arterial pressure, the velocity time integration, the left ventricular ejection fraction,
Pulsatility.
yeah, pulsatility, tissue Doppler, the mitral annulus peak systemic velocity, the right ventricle.
Systolic.
Oh,
Yeah.
sorry,
Peak
systolic.
systolic
Yeah,
velocity.
sorry, systolic velocity, the right ventricle, the cardiac index, the pulmonary capillary wedge pressure, the central venous pressure, etc. But if you look at step 1, they'll talk about that. First off, the cardiac failure must be recoverable. I mean, I don't know why that's so plain in VA ECMO, yet it's not so plain in VV ECMO.
Understood.
You know, of course, we're going to look at hemodynamic stability. You must have, they found that a pulsatile arterial waveform for at least 24 hours before you consider weaning, a baseline MAP greater than 60, and you also have to be either no catecholamines or low doses. The patient should also have recovered from any major metabolic disturbances, so no high lactates, of course. Pulmonary function should not be severely impaired. And you can see that they're talking about the PaO2, FiO2 ratio and having a greater than 100 when FiO2 and the ECMO gas volume set to 21%.
Wait. Time out. If the patient is on VA ECMO, you're not setting your ECMO gas flow to 21%. There's just no way in heck you would do that. I mean, that's a lethal maneuver. But that's what it says.
Is that what it says?
It says if PF ratio less than 100 when FiO2 and the ECMO gas flow is set at 21%, consider bridging the patient from VA to VV ECMO.
Yeah, it sure
That
does.
is what it says, and that is a
Yeah,
John. Would you ever advocate for that?
Yeah, I think somehow that they were trying to say something about VV ECMO here because
Yeah, because
we
you would
could tell
never,
them-
why would you wean oxygen
Yeah.
on VA ECMO, correct?
Well, that's what it says. Bridge the patient from VA
yeah, it
to
says
VV.
that, but there's
Yeah.
something.
The editors screwed this up. Somebody didn't read this
Yeah,
because that makes no sense.
yeah.
Go ahead. I'm sorry.
Okay, so we'll leave that last part out, but pulmonary function should not be severely impaired. That is
Agreed.
correct.
Fair enough.
Okay, the patient must tolerate a full weaning trial. You're looking at hemodynamics, looking at an echo, gradually decrease from 66 to 33 baseline value, and then a minimum of 1 to 1.5 liters. And then if steps 1, 2, 3, and 4 are all validated, the patient is under minimal ECMO support. The EF is greater than 20 to 25%. The aortic VTI is greater than 12 centimeters. The TDSA is greater than 6 centimeters per second. The 3D RV ejection fraction is greater than 24.6%. Then all of those things, you should be able to successfully remove the ECMO.
Mm-hmm.
Yep.
Yep. I mean,
And
I think that's fair.
that's it.
Yeah. So,
You can take my slides down. Thanks, guys.
no, don't take them down.
Oh, no, not yet?
put
You
'em
want to
back
go back
up.
to something?
Yeah, I want to go back to that previous slide. I
This,
think,
this mess up here?
yeah, it's not your mess up. I mean,
No.
I think that it's I think it's. I mean, I want to make sure that I'm not reading it wrong, but
Well,
I don't
I've
believe
got the
I
article
am.
right here. So let me
Mhm.
look into it just
So
a
while you're
second.
doing that, I think
think-
what I don't see here is I
Mhm.
don't see anything about retrograde flow trying to wean off of ECMO. I
Well-
don't see that.
Right.
Mhm.
This article was also published a little bit earlier, so, it was
Oh, they
published,
didn't have the benefit of it? The idea?
I don't know, 2019. So
Yeah.
they're not in the same timeline.
But I think pulsatility is critically important. I think having a why do we keep getting these crazy messages from this Yukio? I mean, it's all spam, and I keep reporting her. But is there a way to stop this, guys? At
In
all?
our chat, YouTube chat?
Yeah, I just keep deleting it. It's
Oh,
killing
okay.
me.
Oh, sorry.
Um,
Do we have
you
any
know.
comments from anyone?
No, we don't. But we have viewers.
Oh.
We have good viewers.
I mean, I don't-
I'd
I
love
don't-
for somebody to call in. I'd like for somebody, because if anybody thinks they're going to win anything today, they're not going to win anything if they don't call in.
Right, and we've
I'm
got all
not spinning this wheel.
We've got great stuff, and
We've got great
don't
stuff.
deny me spinning the wheel, guys. It's
Yeah,
my
we'll spin
favorite.
the wheel. We'll spin the wheel for me. I'm getting something because I get nothing ever. No, I think that weaning from VA ECMO. John, what do y'all do? Just tell us what you do, because I can tell you how I do it, but people are sick of me. Tell me what you do.
Well, actually, we wean VA ECMO, of course, with flow, and you wean VV ECMO with either FiO2 or just keep decreasing the sweep. Actually, is what we kind of do. We kind of wean the sweep way down
Yeah.
on VV ECMO, which is, I don't know how we kind of fell into that habit, because I was telling somebody the other day, you should just be turning the FiO2 down, but we've gotten to where we keep decreasing the sweep down to very, very tiny amounts on
You're
VV.
talking about VV or VA?
Well, we wean sweep on VV, and we wean flow on VA, right?
Right.
That's-
Right.
I
Right.
found-
That makes sense.
Okay, I have a.
And I don't have a problem. It depends if you're, and we see this a lot, right? Is the primary problem with this patient oxygenation, or is the primary problem with this patient CO2 removal with their lungs as we're trying to wean the VV, or is it both, right? If it's both, they're probably not going to wean very well. But, if they're, I've seen this before, and at first I really didn't appreciate it when I first saw this, but people allowing for the PCO2, permissive hypercapnia is fine, but I mean, I was seeing it at 65 and 70 in order to give the patient, as long as you can keep the pH above 7.3 or above, and I've seen 7.9 accepted, in order to let the patient's kidneys compensate and get the bicarb level up and have a compensated respiratory acidosis with a metabolic alkalosis, so that you could get the patient weaned and they could survive in an environment of hypercapnia, because that's where they believe they were going to be. If it's oxygenation, it's a completely different problem. And I've seen it go both ways, where the patients just were so hypercapnic, but their PO2s weren't too bad. They were sat in 92, 94% on a little bit of vapotherm, but their PCO2s are 65, and their pHs are 7.38, 7.4, 7.42, because their bicarb levels are 40.
Okay, I found the specific here.
Okay.
Okay, so it's just a short paragraph. Furthermore, pulmonary oxygenation of the blood must not be compromised. The PaO2 FiO2 ratio should be more than 200, and the oxygen fraction delivered by the ECMO circuit should be 21%.
That's just a mistake.
And that, hold on.
Unless it's VV.
Yeah. And that delivered by the ventilator circuit should be less than 60. These measurements should be made 10 minutes after having decreased the ECMO flow and sweep gas, that is, with an ECMO flow less than 1 liter per minute and sweep gas of 1 liter per minute for 10 minutes. But listen to the references that they have for what they're using for this particular paragraph, the pulmonary oxygenation. They're good references, so it's pretty interesting. Okay, so first article that they used was a position paper for the Organization of ECMO Programs in Cardiac Failure in Adults. It was published in 2018 in Intensive Care Medicine. Good journal.
Good journal.
Okay. Then they also used how to wean a patient from VA ECMO, Intensive Care Medicine, published 2015. Another good one. Okay, then I believe this is the ELSO. Yep, ELSO guidelines for cardiopulmonary extracorporeal life support, version 1.3, November 2013.
Well, I'm going to go on record.
Yeah, no, I know.
Okay, I'm just going to go on record and tell anybody that's watching this program
Yeah, you don't wean FiO2.
that if you're on VA ECMO, if you're pumping blood through an oxygenator into the arterial tree, you never turn the FiO2 under 100. You just leave it at 100, and that's all there is to it. You would never decrease your FiO2 to 21% and pump deoxygenated blood essentially into the arterial circulation.
Doesn't make any sense.
Don't ever do it. That's all I can tell you. I think it's just a mistake. I don't think they actually do this. I think they just made a mistake as they were writing it. Something went horribly wrong and the editors missed it. Or I don't understand it. I don't think I don't understand it. It seems to be saying what it says, but in my view, and I'm just going on record, I don't know if you want to go on record with me, don't ever do that. Do not ever decrease your FiO2 on your circuit for VA ECMO in order to wean.
Well, maybe Joe, they're doing the retrograde flow.
Yeah. Well, if you want to do that, that's fine. But and that's fine if you want to do that. I don't necessarily think that is quite as bad. I don't think it's either one is really a good choice. I don't like the retrograde. I don't think the retrograde flow makes any sense to me.
I don't think it hurts anything.
I'm not sure of that. I'm not 100% convinced that's true. I think that stealing 15 to 20% of your cardiac output can be problematic. So, and I don't think that the amount of increased oxygenation on the right side, especially if you don't really have primary lung disease, even if you did, it wouldn't be enough to benefit you.
Yeah.
So, I don't know. I think having a big AV shunt of 15 to 20% is pretty significant. I don't think I would do that either. I don't like that idea. I think just reducing your flow, making sure the patient is anticoagulated. Anytime you reduce your flow in the ECMO, I have no problem with high ECMO flow, and even in VA ECMO with minimal anticoagulation, I don't necessarily like none. VV, we get away with it. VA, I'm not so sure that I like that, although people may do it. I don't know if you guys do it down there, John, or not. I really don't know. But I would say that just make sure that, for me, my comfort zone is a little higher anticoagulation if the patient's not bleeding, and reduce your ECMO flow, continue to reduce it, monitor your echo, look at your inotropy and pressor need, and look at your metabolic parameters. And if the patient, I think we know if the patient looks like they are successfully weanable or not if you do a 24-hour, wean lower flow kind of situation where you're only flowing 500 or 600 cc's and they're doing fine, they should do okay. That's my view.
Yeah. John, do you want to close up? Have any final comments on this before we get to your segment, Knowledge Nuggets?
No, I thought that was great. I really like the sofa aspect of that. I think I'm going to see if I can look into that a little closer because I have a feeling that if we were to put 90% of our COVID patients on that sofa score, the mortality rate would be really high.
Yes.
Our predicted mortality,
Yep.
right?
Yeah.
Because,
Right.
you know, the thing about this COVID patients, they're on multiple pressors and multiple heavy doses of sedation. The amount of sedation that these COVID patients are requiring to keep them down is almost mind-numbing.
It is.
We
It
have
is.
3 or 4 everything known, and then we add ketamine also for a topper. They're on sometimes double and triple the max dose of more than one. And we had a patient sitting there talking to us one day. It was unbelievable. And I see this in my travels too. I recently went to 4 different places last month, and it's the same everywhere. The patients are on unbelievable amounts of sedation, and as soon as one of them starts to wear off just a little bit, they start thrashing, they start fighting the vent. You got to put them right back on heavy sedation again.
Mm-hmm.
Yeah, it's really
Well, and just to
unbelievable.
talk about that just a little bit more too, and we've seen, which I'm sure this is common, it's just we're not normally around for this, you know, because we haven't had awake ECMO patients really in our hospitals until now. But now once they're awake, because we've had several that, you know, were sedated, intubated, put on ECMO. Eventually we, you know, woke them up, put them on a trach, and they're awake, and they need so much just to stay comfortable because they've been on just these incredibly high amounts of sedation for so long that now they're awake and they're
addicts.
Well, that's what I was going to say. We've created these addicts, and it's terrible to watch. Really is, because they really are miserable.
Well, you know, they're on high doses, they become high tolerant, then they become addicted. But my question is, what is it about this virus that makes people require these enormous amounts of sedation? Have you ever seen this before, Joe?
I'm not sure. I
mean,
guess I've thought about this. I mean, you have a good
People
question.
come in with the flu.
Yeah,
People
no,
that
it's
use COVID. People come in with flu A, flu B, even SARS and MERS. Did these viruses prompt 3 or 4 max dosages of several sedation medications like this?
Do you think it's?
I don't know.
I don't think we saw that in the first wave. And I of course, I have thought about this, and maybe it's the, you know, incredibly, you know, youthful, the young age of the patients that we're getting, and maybe that is the differentiator of needing to use so much. I mean, a 60-year-old or a 55-year-old may not need as much as a 19 or 24-year-old. So
Maybe.
it's hard. I don't know. I don't know if it's their metabolism gets ramped up so high it clears it faster. Good question. I don't really have a good answer. I don't know. I don't know if it's the virus is driving it. It may be something else.
Well, and I was going to say too, part of that may be playing into that COVID. You know, our COVID ECMOs are so severely sick that if they aren't at a complete just complete sedation where nothing is going on, then their oxygen consumption, even though it's minimal, is just that enough to be that tipping point where they desat.
Yeah, just too much. Well, that's what, of course, Dr. Patel talked about this morning, is can we really achieve enough flow in order to be able to overcome their hyperdynamic? And we put the flow track on people, and I saw cardiac output the other day of 16 liters. Not on a big patient. It wasn't a big, huge patient. Their cardiac output was 16 liters. And their peripheral arterial saturation coming out of their radial was, 72.
Yep.
And it was just nothing I could do.
Yeah.
You know, it's just I felt completely hopeless. I mean, it's helpless rather. It's very I felt hopeless too, but it's frustrating. But anyway, with that said,
Yeah, let's get into knowledge nuggets.
Let's run an intro on John Ingram's knowledge nuggets. You ready? Go.
All right.
Dude, your picture, you look a lot older than your picture. And it's only been a couple of years, not even a year. No, a year.
Yeah, well, it's a couple of years of COVID, Joe.
Yeah,
no
really.
kidding.
I know.
All right, well, let's get into it. John, the floor is yours.
All right, okay, so Knowledge Nuggets, episode number 13. Today's October 6th, 2021, and I'm your host, John Ingram. Of course, with this particular episode and all previous and hopefully in the future, I will not have any disclosures on this topic. So at Knowledge Nuggets, our motto is spend a little time and expand your mind, and hopefully with a little nugget of knowledge that we're going to give you today. This week's topic is recombinant factor 7A. So if you haven't watched before, the format of the show is we give you a noteworthy topic each session, hopefully, and we hope to give you something you can take home as a little knowledge nugget that you can bring to work tomorrow. If you see a golden nugget in the upper right corner of the screen, that's a screen you can snapshot, screenshot, take a picture of it, take it with you at work tomorrow, and hopefully be a better clinician at work from now on. It's a highly impactful segment, 12 to 15 minutes. Then we do a surprise topic, a little quick down and dirty topic that I select, could be anything 2 to 3 minutes, followed by panel discussion and questions about 15 minutes. And then if any of you guys ever want to comment, have a suggestion for a future show or question, anytime, please email me at john.ingram@perfweb.us. So what is recombinant factor 7A? So here's a knowledge nugget right off the bat. The definition of recombinant factor 7A is it was FDA approved for the treatment of bleeding and for the prevention of bleeding and surgical or invasive procedures in patients with acquired hemophilia. That's what it's FDA approved for. Recombinant factor 7A is indicated for perioperative bleeding management in adults and children 12 years and older with hemophilia A and B with inhibitors, congenital factor 7 deficiency, Glanzmann thrombocythemia with refractories to platelet transfusions. And we're going to discuss a little bit of that as we go on. Also, in people with hemophilia type A and B who have a deficiency of factors 8 and 9, which is what hemophilia A and B are, these two factors are administered oftentimes for bleeding as a prophylaxis medication prior to surgery. However, some patients develop neutralizing antibodies to these medications. They're called inhibitors against the medications for what they're being given, factor 8 and factor 9. These inhibitors, which are antibodies, often increase over time and inhibit the overall action of coagulation in these particular patients that already have hemophilia A or B. So recombinant factor 7A, which is an activating form of factor 7, bypasses factors 8 and 9 and causes coagulation without the need for the factors 8 and 9 to be functioning or present. The trade names of factor 7A are Novo7, Oreo7, 7-Fact, and there's actually a few more than that, but Novo7 seems to be the most common one. So what is the dosage you might give a patient? Somewhere between 75 to 225 micrograms per kilogram IV every 3 hours until hemostasis is achieved. And we're going to talk about this, guys. Remember a week or two, a couple sessions back, we had a conversation about protamine, and we were talking about how some people have the misconception that protamine is a procoagulant. Protamine is not a procoagulant. It's a reversal of heparin. And if given in too high of doses, protamine is actually an anticoagulant. But in the fact of recombinant factor 7A, It is strictly a very powerful procoagulant. And you have to give this in very small doses and be very careful because it is a strong procoagulant. We're going to look at this a little bit here coming on in the next few slides. So let's look at the coagulation cascade. So if you look at the coagulation cascade, of course, everybody's familiar with intrinsic pathway, extrinsic pathway. And what you have here is patients with hemophilia A have a factor VIII deficiency. So with a factor VIII deficiency, you cannot produce factor Xa, which is right there at the pivot point of the common pathway. So factor X, production of factor X and factor Xa is absolutely vital to being able to produce an eventual clot there at the end. So go ahead. So the next thing is when you have hemophilia. Go ahead with the slide. I think it's going to go on to
Oh, there we go.
hemophilia B is a deficiency of factor VIII, okay, or factor 9. That's a typo. I'm sorry. Factor 9 is hemophilia B, and factor VIII deficiency is hemophilia A. So that's a typo. But without factor 9 activating factor VIII, you certainly cannot activate factor 10. So this is why hemophilia A and B have such a problem with bleeding, because they cannot produce the eventual factor A, factor 10, I believe, factor 10A, which will produce your clot. So where does factor 7A come in all this? Go ahead. So how does recombinant factor 7A affect the coagulation cascade? So factor 7A, which is the active form of factor 7, bypasses factor 8 and 9, as I mentioned, and causes coagulation without the need for those two factors, 8 and 9, as I was just mentioning. So if you look again at the coagulation cascade, by the way, guys, these slides are going to progress automatically. You see there factor 7A is on the extrinsic side. It directly promotes the production of activated factor 10A. So therefore, you don't need factor 8A or factor 9 as in hemophilia A and B, because factor 7A directly produces and activates factor 10A. So that's the huge benefit of giving factor 10A.
Which is
So
your
now,
common pathway,
Yeah,
right?
right.
Factor 10 is your...
stimulating right what you need to. So patients with hemophilia A and B, basically this is a tremendous benefit to them, because regardless of their deficiency of factor 8 or 9 or lack of function of 8 or 9 becomes irrelevant, because it activates factor 10 without the need of either one of those. So what are some serious warnings and complications, though? Because there are serious arterial and venous thrombotic events that have been reported with factor 7A activation. Congenital hemophilia receiving concomitant treatment with activated PCCs, prothrombin complex concentrates. If you have a patient who's already receiving that and you add factor 7A to it, you can have some serious arterial and venous thrombotic events. Older patients with acquired hemophilia and are receiving other hemostatic agents, and you add factor 7A onto that, have experienced some frequency of arterial and venous thrombosis. Patients with a history of cardiac and vascular disease, and patients with indwelling catheters such as chest tubes and ECMO. Now, not always, but you can have successful treatments of patients on ECMO or indwelling catheters, which all of our patients are going to have with factor 7A. But because it's such a powerful procoagulant, when the factor 7A enters the system, and as you guys know, blood comes in contact with these artificial surfaces, we have seen major clotting off of chest tubes, and then, of course, blood filling into the chest and complications with that, and also ECMO systems clotting off. So if you're going to give factor 7A on ECMO, you better really be very careful and do it with very small amounts, and really cross all your fingers and toes that you don't clot off the ECMO circuit. So in the military here, not so long ago, they used a lot of recombinant factor 7A during the Iraq War. And when patients were bleeding, they would just give them factor 7A as a desperation measure to stop bleeding. And it does work very well. However, so, you know, it was credited with saving many lives, but they also saw a high number of DVT, deep venous thrombosis, pulmonary embolus, as well as unexpected strokes, heart attacks, and deaths. And as you know, guys, these are all very young people that they're giving this to. And so to have, strokes and heart attacks, you can see the impact that this is a pretty powerful prothrombotic drug, procoagulant. So now, the gem of the week, guys, we're ready for that. And as you guys know, if you've never watched before, the gem of the week can be absolute anything that I decided to be. It could be something in the world of trivia, could be on how to succeed in an interview, or maybe a virtual interview, which I think we did a couple months ago, that one. We could talk about a career opportunity out there. Joe mentions he's still hiring out there in Houston, which is a great city to work. We could talk about something in perfusion news, like a product recall. We could talk about something that occurred during Perfusion Week. One time we took a famous quote from Einstein, and we did that and talked about something to do with the knowledge of a famous quote and the implications of that. And we can always talk about a famous or an upcoming conference coming up. We got to change that to 2022, right, Joe? So this episode's gem of the week is going to be Merck's pharmaceutical oral antiviral drug. I don't know how to pronounce this very well. Molnupiravir, treatment for COVID-19. I don't know if you guys have heard this, but this is just now breaking news. Molnupiravir, it's in its phase 3 trial. Go ahead, guys. So what we see is Merck's pharmaceutical oral antiviral Molnupiravir reduced the risk of hospitalization by 50% compared to placebo for patients with mild or moderate COVID-19 in a positive interim analysis of phase 3 study. We're going to talk about what all this means. Molnupiravir, the interim analysis evaluated data from 775 patients who were initially enrolled in the phase 3 trial just prior to August 5th of this year. Now, at the interim analysis of the phase 3 trial, in other words, they just don't do a complete phase 3 trial and wait to the end and say, oh, by the way, this wasn't working. They halfway through the phase 3 trial, they take a stop and they take a look and say, hey, what is the data showing us? And it showed them already that they reduced the risk of hospitalization by 50%.
Wow.
So now check this out. Eligibility criteria required that all patients had a laboratory-confirmed mild to moderate COVID-19 with symptoms within the first 5 days of the study. All patients were required to have at least one comorbidity risk factor associated with poor disease outcome at the time they entered the study. So in other words, these weren't people that, oh, I just tested positive for COVID and I've never had any symptoms and they gave me this drug. No, this had to be people that were symptomatic and had at least one comorbidity, which, as you guys know, diabetes, heart disease, obesity, and so on, pretty significant comorbidity. So they had to have a pretty decent risk factor, and they gave, this is the patients that they used in the trial. So I thought that was important. Then, additionally, based on the participants with available viral sequencing, approximately 40% of participants, Molnupiravir demonstrated consistent efficacy across all viral variants, including Gamma, Delta, and the one people are talking about next called Mu. It had equal effectiveness no matter what the variant was. 7.3% of patients who received Molnupiravir were hospitalized through day 29. So you're talking about 385 patients that were given this. There was 742 altogether. 385 were given the drug, and then 377 were given placebo. But 14.1% of the placebo-treated patients were hospitalized. So basically half of the hospitalizations after day 29 of having active COVID. So then, through day 29, though, no deaths were reported in the patients receiving Molnupiravir, as compared to 8 deaths in patients who were receiving placebo. At the recommendation of an independent data monitoring committee and also with the cooperation of the FDA, recruitment into the study is now being stopped early due to these positive results. In other words, go ahead to the next slide. They were going to eventually obtain 1,500 patients. took another 750 patients and realized half of those were going to get a placebo instead of the drug, rather than submit people to that, with the results they've already found, they're going to submit early use authorization to the FDA, and they're going to stop the phase 3 trial. So they also plan to submit marketing applications to other worldwide regulatory bodies besides the FDA here in the U.S. So at the time of the decision to stop recruitment based on the compelling interim efficacy results, the trial was approaching full recruitment of the phase 3 sample size of 1,550 patients, with more than 90% of the intended size had been already enrolled. So they're progressing with the study, going on to the second half of the phase 3 trial at the time. Now, basically, it was in the last week, I believe this all happened, to stop the trial and go on with what they've been able to do so far. Reduce the risk of hospitalization. The drug reduced the risk of hospitalization and or death across all key subgroups, meaning all comorbidity categories of patients. Efficacy was not affected by the timing of the onset or which type of underlying risk factor the patient had. The incidence of any adverse event from the drug compared to placebo, it was actually lower. Adverse events from the drug were actually lower than the placebo group. The placebo group had 40% adverse events. Molnupiravir had 35% adverse events. And then we looked at the incidence of drug-related adverse events between placebo and the drug was almost identical, 12 and 11% respectively. So this is showing that the drug is not causing any adverse effects compared to placebo.
Wow.
All right, guys, so that is the Knowledge Nuggets episode number 13, I believe. And if you guys have any email comments or questions, please email me at that web address there, and I will respond to all emails that come to me.
John got a very good, excellent, very good job.
That's
Thank
incredible.
you so very much. And it's really interesting to hear about this new antiviral and how that's going. But that's another. I do want to discuss that. But I want to ask this question from Joy Patel. Are there any special considerations or interactions with the activated factor 7 with antifibrinolytics such as Amicar or TXA?
Well, the reason you're giving factor 7 is because your patient has very serious bleeding complication. Factor 7, the military gave it as a first-line drug, it sounded like, on that article that I pulled up. But as you guys can probably attest to in the hospital, it's sort of more of a last-ditch effort. It's not the first thing you give patients, right? You've tried everything else. Yeah. The bleeding is still persisting, and you have to be pretty seriously getting close to desperate to give factor 7. And the reason is because, well, first of all, it's extremely expensive, but second of all, it is a procoagulant. So if you have any risk factors involving, the patient clotting off or having thrombotic events, we see this at our institution. Anecdotally, we see it quite a bit. But if you research the studies, it actually shows a pretty low incidence of it. But I can tell you anecdotally, on our end anyway, we get very nervous when we give patients factor 7. How have you seen that there in Houston?
I've only given factor 7 one time, and it was a disaster. I was in Louisiana.
I've never given it.
Almost. You're right. I've seen it given.
Well, I mean,
participated
I've never
in the case where it was given
I've
one
never
time.
had a patient that has received it, to my knowledge.
Right. I've only had one, and it wasn't a good outcome. So I don't know how much you use it. Now I know we use that Kcentra.
Yeah, Kcentra.
A lot. I've used that several times.
Yeah, I've done that maybe 3 or 4 times just in the past couple of years.
Yeah, but I haven't really. I just don't have any experience with activated factor 7. I know that there was that. What's the name of that fellow that? I think he's with Specialty Care now. They do their webinars too. I can't remember his name now.
Al?
Yeah, Al Stammers. That's the guy.
Okay.
I know that he years ago somebody, it's been like probably a decade, maybe longer. Somebody had gotten up and gave a talk on activated factor 7, and he was very impassioned against the use of it.
For perfusion
And,
related things, or
well,
what?
no, just for bleeding in general.
Oh.
He felt that it had such profound hypercoagulability that the risk was too great to use. I don't know what his stance is now. At least that's what I recall. That's how I recall it. I don't want to misquote the guy, but he seemed pretty negative against it. Of course, I'm thinking to myself, I mean, do you want to bleed to death or do you want to clot? I mean, I don't know, it's desperate.
The reason probably why he was saying that, I didn't see that talk, it was quite a long time ago, but I can tell you in my research of this, when I showed the dosage range, which was 75 to 225 mics per kilogram, even at the 75 mics, it's something on the order of 500-fold to 1,000-fold the amount of factor 7A that we normally have in our system.
Mm-hmm.
I think that's part of why that is. I'm not sure. Why can't we reduce the dose to where it's just a minor amount more? But for some reason, when I was looking into this, and this is not a research paper, but it was actually clinicians that I know that have given it, and I was interviewing them about this talk, and they said it's like multiple hundreds times the amount of factor 7A that we have in our system. So, it's so powerful. I think that's probably why he was saying that. It's so powerful. But when I did the research, I figured I'd find all kinds of complications and people having, 30, 40, 50% incident of thrombotic events. And I found it, most of the research for it to be way down around 5%. And even on ECMO, they found it to be low. But in our experience, I can tell you, it's not that low. It's very scary. Even with a patient off ECMO, and let's say you have 2 or 3 chest tubes and you need those chest tubes to work because the patient's bleeding, the patient clots so severely that the chest tubes literally are filled with a snake of a clot. And then the patient, has a pneumo and things like this.
Hemothorax. They get a tension hemothorax. I remember one time, so I don't know if we answered your question, Joy. From my perspective, intuitively, I guess, speaking, if you're, the anti-hyperfibrinolytics like Amicar and tranexamic acid are really designed more for just that. You have hyperfibrinolysis. Two completely ends of the spectrum.
Yeah,
one's
a
there
a very small.
One is for not having your clot dissolve real fast.
Right.
And the other is just to form a clot. So
right.
If you think your problem is hyperfibrinolysis, then you're going to want to use anti-hyperfibrinolytics.
Mm-hmm.
But if your problem is you just can't form a clot,
yeah.
then that's a completely different
pathway.
I don't see it.
Yeah, that as well. But I was also just saying 2 ends of the spectrum of more normal use,
yes,
extreme use.
Yes. The potential side effects of Amicar TXA are extremely low.
Yeah.
What's up?
Oh yeah, I hadn't forgotten. No, I'll get to this. This is going to be part of my closing, but I want to finish out this.
So I hope we answered that question, Joy. I think that really we would need to invite a serious hematologist into this
We need to get one of those in our faculty. We don't have one.
No, we really don't. No, we've done one. I think we actually had one. We actually did, I do believe, at some point in time in the past.
I see.
Way early, predating you.
Predating me.
Predating the Tammy Sparacino.
I haven't gotten through the entire library.
Joy says thank you, so you're welcome. But yeah, I mean, we give Amicar and TXA prophylactically, we put 5 grams in the pump. We give 5 grams before they do the sternotomy, it's pretty much routine. I just don't think that it would, if you're getting to factor 7 level, you're in a lot of trouble.
You're on a different road.
You're on a different road, yes. Now, you might have low side effects, such as thrombotic events, but that might be because the patient never had the opportunity to to really be diagnosed for that because the outcome was poor.
Yeah.
I think you're really in a lot of trouble, as you saw from the from the injuries sustained on the battlefield, where you just
sure.
have profound, uncontrollable bleeding, and that's probably occurring from massive transfusions and having had so much blood loss
Yeah.
that they just became coagulopathic, and there was no way to, at that point in time, stop any bleeding. So again, you're confronted with a problem of, do you
Well, and I
bleed to
think
death, or do you take the risk
Mhm.
of clotting everything but possibly stopping the bleeding? If you know this is going to kill you, then, or the patient, then you need to do this, and it may still kill the patient for a different reason, but it might not. So I mean, that's really what you're that we're always in between the rock and the hard place. It just seems to be the way it all is.
Right. Well, especially in that circumstance when they were, they were out in a war. They're not in a hospital with the luxury of making,
Yeah.
Measured decisions. They have to react.
Yes, absolutely.
Yeah.
Absolutely. Yes, that's very true. The time for polite hand wringing is not there.
Right.
Right.
Exactly. John,
Yeah,
any
the-
final thoughts on your topic there?
Yeah, the thing with what the I guess it was Joy was saying there. If we're talking about in the ICU, right? With this, we're not talking about in the OR. We're
Right.
not going to get. So in the ICU, you're running your coag blood test, and if you see that you have fibrinolysis, your elevated D dimers, your fibrin split products are very elevated, you have fibrinolysis going on, then you would give Amicar TXA. But if you don't have but if your problem is not that, and your problem is you have very high, PTTs, you cannot coagulate, then you have a coagulation problem.
Mm-hmm.
And if you're just not able to correct the problem, I guess at some point you might try factor 7. But from a perfusion standpoint, and from a cardiac ICU nursing standpoint, you have to be very, very worried when you get factor 7A, because it's already activated, by the way. It's factor 7 activated. And it's going to immediately activate factor 10, and you are going to zoom down that common pathway and start forming clots a lot of places everywhere. And hopefully it's where you want them and not an overabundance of where you don't want them. But obviously we're at the mercy of some higher power greater than us to determine if that's how it's going to work out or not.
Yeah.
Well, I can guarantee you one thing: don't give it while you're doing retrograde flow weaning off of ECMO. But I do want to say, I know you want to close out. I do want to say one other thing, and this has to do with the antiviral that you talked about.
That's very exciting, by the way.
Just
Thanks
a moment
for sharing
ago.
that.
Yes, that is. It's good news.
Absolutely.
Yeah,
But,
glad you could use
you
some
know-
good news in the last 4 months of what we've
Yeah.
been through.
God, no
Just some-
kidding.
But
Maybe there's some hope on the horizon. I don't know, with this drug or maybe another. But
yeah, and I think treatments make a lot of sense. But I'm going to say this, again, I'll be happy to go on the record. Get vaccinated. Just get vaccinated. I understand this whole argument that's going on about natural immunity. You got COVID and you recovered from it, whatever the case may be, and maybe you do have antibodies, and or maybe you haven't gotten COVID, or you just thought you had COVID. Have you really been tested for antibodies? Look, get vaccinated. That's all I can tell you. We have not one patient, not one of our patients, and I have seen more death than I ever care to see ever again in what has been a 4-decade career. I have never seen this level of death of young, healthy, otherwise healthy people, even with some comorbidities that would not really affect their overall longevity whatsoever, die in the most horrific way, and the degree of pain and suffering and despair that I have seen families go through with young children, 19 years old, my grandchild's age, with the mother putting a figurine of Jesus on their head, praying nonstop. You told me about this. You actually experienced this.
She did a vigil. She never stopped praying
And
the entire time. And when I say praying, I mean like chanting praises and for please intervention. And I'm talking hours and hours and hours and hours.
And this is a mother who I believe you told me that she said that she was praying that he's my only son. He's all I have.
He's my only child.
My only child, right?
I only have him and my mother is elderly.
Yeah. I mean, this is real. For anybody that doesn't think this is real, I mean, and this kid's 19 years old.
Barely 19.
Barely 19 years old. Did not get vaccinated. Had told his mom he had gone and gotten vaccinated because she was pressuring him, begging him, imploring him, whatever you want to call it, to get vaccinated out of love and concern for him. And he said to get her off, basically to make her feel better. And these are decent people. And we have, I've never seen anything like it, but not one patient we have, not one patient is a vaccinated patient that we have had to manage. And I was really surprised to listen. And listen, Vanderbilt is an incredible place. These people are very smart, and I think we should be looking to them for some guidance. But I'm seeing the exact same thing in the medical center. They're pulling back from using ECMO for COVID ARDS because the outcomes have been so bad. And but I was surprised that we, as a group, have done more ECMO.
I know, than Vanderbilt.
More patients we have treated with ECMO as a bridge, not as a treatment, because it's not a treatment. I want to make sure I'm clear on that. It doesn't cure anything. We have done more cases than they have.
For COVID.
Patients, right, for COVID,
Yep.
correct.
By quite a bit, actually.
Yes, and not one, I challenge you to show me one that was vaccinated or previously infected. I mean, whatever. I don't know. I just know they're not vaccinated. And I'm sorry, if you don't want to believe the science of the vaccination, you don't want to believe that it does any good, you don't want to believe it, you don't want to take it because you don't trust the science of the vaccine.
Some people
then
don't want to be told, and it's come down to just that.
Well, let me tell you what, you come to the hospital with severe ARDS secondary to COVID, and you are going to be a science experiment because that's exactly what it is. Yeah. And our outcomes are horrible, and I'm just imploring everyone to get vaccinated. Yeah. That's all I'm saying. Just get vaccinated, because if you get this, it's and you look, 98% of people are going to do just fine. I agree. I'm not arguing the point. I can't argue it because it's true. Facts are facts. But if you get it and have a bad reaction to it, you're in trouble.
You mean COVID?
Yes, COVID. That's what I'm talking about.
Not the vaccine.
No, COVID. People will have, right, most people that get COVID will recover from COVID and do just fine, the overwhelming majority. But that percentage that do not, it's devastating. It is absolutely devastating.
Well, and it's important to talk about that getting it once does not mean you won't get it again and continue to spread to others. Even if you're that person that can get it and be fine, you can get it again and still be fine, but you are still carrying a viral load that you can spread to people.
Could you imagine being a patient? And we've had a few that have come to us. We've gotten them on ECMO, and they've gone to the medical center and gotten a lung transplant. You get the lung transplant, now you're immunocompromised. So even if you get vaccinated at that point in time, you're immunosuppressed. So you're out in the community trying now to have some semblance of a normal life, and somebody who doesn't want to get vaccinated, who is one of these that you're talking about, it can get it and do just fine, don't even know they have it, and transmits it to you, and transmits it to you, to that person, they're toast. They're absolutely toast.
Well, and I mean, we had a specific, this is a real person, a patient we had who got it, was put on ECMO very early. Oh, is that not where it goes? Sorry.
No,
was
that's
put
all
on ECMO very early, was doing quite well, was just waiting for a lung transplant. I mean, talked to this patient every day. We spent lots of time with them.
Roger?
Yeah.
You're talking about Roger?
I am.
Yeah, that was brutal.
And he got reinfected by, by a visitor. And
In the hospital?
In the hospital.
ICU?
In the ICU. And I guess we can't ultimately say it was from this, but he became positive again and through a pulmonary embolus.
Died.
And died.
Well, we believe he threw a PE.
Yeah, again, we can't be
believe that.
positive, but that's what they think.
Right.
And he had been doing well for 5 weeks or so, waiting for his lung transplant ticket.
So get vaccinated. That's all I ask.
Okay, and I'm going to end on a more positive note because I hear there's
I thought mine was pretty positive.
Nope. It's midweek. We gotta have some positive vibes. But John, you're in Key West, beautiful Key West, and I bet the sunsets are just great. Let's talk to us about your scooter and your adventures on it.
My brand new scooter, because I traded in my really big, heavy 850-pound Harley after 20 years for a little 200-pound little mini bike scooter, which I rode for the first time last night. And probably because it was brand new and the gas tank had never really been used, and I was out riding, I think some debris went down the gas line. Oh. And basically it wouldn't, I got stranded where I was going. And Magic. It took me almost 2.5 hours to push it 3 miles Magic. Home.
Are you listening to this, Joe?
I'm listening.
He
pushed
went out
it 3.5 miles.
Yeah, but he went out to see a beautiful sunset.
Yes.
Rode a scooter.
Yes. Ran out of gas.
No.
I don't know if you could see it, but
it
I'm going
broke
to show
down.
you.
Oh, it broke down?
And he had to push it, and it took him hours to get home.
Okay. Did you enjoy the sunset?
Well, I'm going to show you a picture if I can get my phone to work properly. I don't know what it's doing, but I'll show you. Oh, gosh. I don't know what my phone's doing here, but okay. So I have a great picture for you guys, if I could just find it. Oh, well, it's not coming up.
Maybe it can be the gem of the week next week, could be your picture of you on your scooter. Or next month, rather.
Okay, here we go. See if you can see this on my phone. That's what I was doing last night.
Okay.
Okay,
nice.
Good for you.
Pina colada and a land shark with a sunset over the ocean behind me.
With your broken scooter?
Not yet. It's not broken.
The scooter wasn't broken yet.
But then when he left.
But there you go.
Well,
so how's that for a vacation?
That's not bad. I think that's great. I think that's great. Well, you know what Harley Davidsons and Hound Dogs have in common?
No.
They both share the same initials, and they both ride in the back of pickup trucks. So, with that said, I bid you farewell. We're going to reschedule Perfweb, the one that we had to skip.
Yeah.
Perfweb 68. We're going to work on rescheduling that. Hopefully, things are starting to look better number-wise and so forth. We may just add that to the Thursday and just do a double whammy. And just do a double whammy, 68 and 70 at the same time.
Did we get a question? So do we spin?
Oh yeah, we did get a question. I am so sorry, Joy Patel.
Yeah.
Joy, I'm so sorry. You're gonna have to send us an email at contact@perfusioneducation.com. And we will, of course, mail this to you. Please don't tell me you're in Mumbai, okay? Because if you are, it's really expensive postage. But we'll do it for you, okay? So, Joy, let us know where you are. Send me your address, and we're going to go to spinning the wheel.
Okay.
So, do you know how to do it?
I
so
can't
just
remember.
Close that.
Here.
Yep,
And
there's
here.
your wheel.
There's my wheel.
Okay. All right.
Do I need
here
a
we go.
mirror again? Okay.
We're gonna spin for John. No, I should hit the spin button. Just
yeah.
push it.
No, I'm not. We're spinning for Joy.
Yeah, we're spinning for Joy.
You said John.
Oh, Joy Patel.
Yeah.
Here we go. I can't hear it.
Yeah, I can't hear any sound, but that's okay.
Well, you got to spin it over again.
No, but what if this is what she wants?
Well, how do you know it's a girl? It's a guy.
Or what he wants.
T-shirt. Okay, you want to
Woo!
show him the T-shirt?
T-shirt's great, yeah.
Just
Yeah.
grab a T-shirt. John, while she's going and getting the T-shirt, tell us about the person who made these T-shirts. And they can enjoy to call me, email me, and tell me what color you want, because we have red, black, and I guess that's khaki or something. Yeah. Oh, yeah.
And,
Can you zoom out, Magic? Can you help us out? Hold on.
Good friend of mine, Alan Klima, made this design, makes the shirts. Basically, complimentary, right, Joe? Sent a bunch to you for the show. And perfusion, cardiac surgery, perfusion, we give your heart a rest, right?
Yeah, yeah, just show that right there. Just put it right up. You don't have to zoom in on it, Magic. Just let it they can see it.
And then,
There you go. We give your
Yeah.
heart a rest. Yep.
and we've got small and
Rotating at Duke University Hospital. Thank you very much. You got it, Joy. Send me an email.
and a size.
I'm so glad you're in North Carolina and not someplace out of the country. And a size.
We've got, let me tell you, because the colors
We have
are sizes.
probably large and extra large.
We have a medium,
Medium.
in khaki, and then extra large in black or red, and one more, hold on, a
Madam.
large if you prefer long sleeve.
Yes, and you know what? We have hats.
Yep.
We have
But he wanted t-shirts.
surgery. Well, he's going to win the T-shirt, but you know what? I'll send him a care package. He's rotating at Duke.
So we've got
Okay,
all
so it
kinds of
sounds
hats.
to me, if he's doing a rotation at Duke, it sounds to me like he might be a student.
Okay.
And what do students need? Care
Stuff.
packages,
They
stuff,
do. We've
right?
also
So
got the surgical cap
surgical cap
or the ball cap.
and the ball cap. So we're just going to send you. You want a T-shirt? Let me know what color and size you want, and we're going to send you that and a couple of other items. Thank you so much for what was an excellent question. I appreciate it so much. And I really feel bad that he didn't get the extra call or the aortic dissection. Actually, I didn't like it because I couldn't hear it, so I think you need to spit again.
But this is just for fun.
Okay.
He gets the T-shirt.
Oh, maybe. But he might get more than just a T-shirt. Now we got sound. Thank you.
With no
Come
video.
on, give him an aortic dissection.
Nope.
Come on.
Gonna be something good. Stop it! You're cheating.
And a cup, okay, and a Perfweb cup. So you're getting one of those too. So
Yeah,
you're
that's
getting
the Perfweb
everything. You're
edition.
getting the whole care package. You're getting the whole ball of wax, Joy. And listen, good luck in your profession. I'm assuming you're doing rotation, so you're likely a student. I'm assuming from that. I could be wrong, but that's what I'm assuming. Good luck in your career. And think of us and tell us how you're doing as you move along. And, you know, as soon as you are eligible for your boards, please call us. We're hiring. Might even hire you now, depending on how far along you are. And we'll just get you right going to work as soon as possible. So thank you very much for participating. That's why we do what we do, is because of people like you. So we wouldn't have a show were it not for people like you. So thank you very much.
Yeah.
You want to close us out, finish this
Yep.
up?
All right, John, thank you so much, as always, for doing a wonderful topic and entertaining gem of the week. This one was very uplifting, so we certainly enjoyed it. Thanks to all of our viewers, and a special thank you to Joey and Dr. Patel from
Oh, yeah.
Vanderbilt for a wonderful segment this morning. And everyone, just have a great week and tune in. When's our next Perfweb?
Our next Perfweb is, so right now I'm looking for the thumbs up. Okay, so I'm going to send that to Joy.
It'll be
he
on a
says he hit the
Thurs-
lottery. It is going to be on a Thursday.
Yeah.
And it is
October
Thursday, October 21st.
Yep.
Go ahead.
At 3 p.m.?
At 3 p.m., but it probably will be earlier because I'm going to do the
Okay.
Perfweb 68 along with it. But the topic is going to be both DO2 delivery, oxygen delivery. Why do you need a perfusionist? And because there's such a, we talk about DO2 all the time, right? But in perfusion, when you're in the operating room and you have to manage, they need to do the operation and they need to see, and the heart's filled up, and
We have different
they're getting
challenges.
lots and lots of challenges. How do we manage DO2, making sure that the tissues are perfused adequately, but also facilitate the reason we're there, right? Protect the brain, facilitate the operation being done. But then we're also going to be talking, not like we haven't done it a billion times, my perspectives on, and I never have a perspective on anything, almost opinionless, I know, my perspectives on how the healthcare industry managed the COVID-19 pandemic.
That'll be
what
uplifting.
is exceptionalism and what is heroism.
Oh, well, it will
And,
be uplifting.
I think it will be. I think it will be. It'll be. There'll be some. There's going to be some pretty strong, pointed messages in there.
Yeah.
Yep,
Good.
I'm sure of it. But with that said, I want to bid everybody adieu, and we'll see you on Thursday, October 21st, barring a fifth wave and a catastrophe, which I am praying does not happen. Thank you all. Good day. John, good seeing you as always.
Thanks, guys.
Tammy,
Good
thank
seeing
you so very much.
Thank you.